Good afternoon and welcome to the Health Committee of the House of Delegates. My name is Vice Chair Bonnie Cullison, who is substituting for our chair momentarily while she presents a bill in another committee. I ask for your patience as we encounter any technical or streaming issues. This hearing is being streamed on the Maryland General Assembly YouTube channel. We do have a few virtual speakers today, so we'll be pulling them up on the screens. Please note that food and beverages are not permitted in the gallery. What you'll see is the delegates may have a drink with us so that we can remain hydrated. Please make sure that your cell phones are turned off or you silence them. And as with our chair, a lot of the members who are here are in other committees as we speak, and they will be paying attention to these proceedings as well. We're going to ask the committee to adhere to our usual committee rules of 1 question and 1 answer from the panel, not 1 question and 1 answer from each panelist. And please keep your questions brief. With that, I'm going to give you the bill order for the day. We're going to begin with House Bill 986. Then we go to 771, 489, 995, 975, 1002, 838, 944, 965, 772. Short day today. So with that, the first bill is Delegate Terrassa. So if you'd come up and bring your panel. This is Nurse Licensure, Educational Requirements, Enforcement.
My speaker's on now. Okay. Thank you so much. I appreciate it. Let me pull my testimony out here. First, let me say it's a pleasure to be here with you, members of the Health Committee. This is, in my 8 years, my first time sitting in here testifying before you. While I've had several bills, they were virtual. So for the record, I'm Delegate Jen Terrassa. Thank you for this opportunity to present House Bill 986, Nurse Licensure, Education Requirements, and Enforcement. This is a cleanup language bill which clarifies and strengthens education verification and nursing licensure process in Maryland. The bill requires applicants for a nursing license to provide clear evidence that their educational credentials are up to state nursing standards. It also ensures the Board of Nursing is able to properly enforce licensed educational requirements. So the problem is recently, national and regional concerns have been raised over diploma mills, falsified transcripts for nursing license applicants. Hearing about this, MDH and the Board of Nurses reached out because they believe there remains some ambiguity in the Maryland statute, particularly for nurses who receive their license through the endorsement process, and they wanted to clarify the board's authority. The bill does not create additional educational requirements for registered nurses in the state. In simple terms, House Bill 986 is meant to strengthen public trust in the Maryland-issued nursing licenses. So what it does is 3 essential changes. First, it creates a statutory definition of valid nursing educational program. Second, it adds the failure to complete a valid nursing education program as explicit grounds for denial of a license or disciplinary action. And lastly, it reasserts the authority of the Board of Nursing to investigate the educational credentials of registered nurses in case of suspected fraud or misrepresentation. So this legislation simply clarifies the investigative authority of the Board of Nursing, so the board can effectively verify educational credentials. These changes will ensure the safety of both patients and nurses in a medical setting. And please note, I've offered an amendment to the bill. There was some back and forth between the department and the drafters about specific language that wasn't finalized before the bill came out. So, but that's been worked out now. I urge a favorable report on House Bill 986.
Thank you. Thank you, Delegate Terrassa. Good afternoon, Vice Chair Collison and members of the committee. For the record, my name is Rhonda Scott. I am the Executive Director for the Maryland Board of Nursing, and I appreciate the opportunity to testify in support of House Bill 986. House Bill 986 reinforces a core principle of professional licensure, that individuals practicing nursing in Maryland must complete appropriate verified nursing education. The bill strengthens the board's authority to require endorsement candidates to provide evidence that they meet the basic nursing education qualifications required under Section 8302A of the Health Occupations Article. This evidence may be requested at the time of application, or in the case of an otherwise facially valid multi-state license, if there is a subsequent suspicion of fraud or failure to complete a valid nursing education program. Nursing requires extensive academic preparation and supervised clinical training. Patients rely on licensed nurses during their most vulnerable moments, and ensuring every nurse has met foundational educational standards is essential to maintaining public trust and patient safety. This bill provides clarity around educational qualifications and supports a consistent review of credentials for all applicants, whether they were educated in Maryland or elsewhere. It promotes transparency, uniformity, and accountability in the licensure process. Importantly, the bill does not change substantive educational standards. Rather, it reinforces the importance of verifying that those standards have been met prior to licensure, or in the cases of potentially fraudulent activity, after a license has been issued. The Maryland Board of Nursing's mission is to protect the health, safety, and welfare of the public. House Bill 986 aligns with that mission by underscoring that educational preparation is the foundation of competent nursing practice. The board believes this bill supports both public protection and continued confidence in Maryland's nursing workforce. Thank you, and I respectfully request a favorable report.
Thank you very much. Are there questions from the committee? I do have a question. Ms. Scott, is this bill the result of us finding that a lot of applicants were coming without accurate or appropriate educational backgrounds, or is it just to codify what we're doing?
It's basically to ensure that the board maintains its authority to require individuals to meet the requirements, the statutory requirements for licensure. And as Delegate Terraza mentioned, the fraudulent activity that's been occurring with fraudulent education programs and transcripts that we've been receiving.
Okay, so it was a response to an issue you were having.
It's response, yes.
Okay, thank you. Any other questions, Delegate Terraza? Tavares. Delegate Tavares. It started with a
Just as
T.
close. It's just as close. It's just this close. Hold on, let me hear you better. Hold on. So just making sure that, are we confirming that the schools that people are graduating from are accredited?
Yes, that's part of the process, the vetting process.
Thank you.
You're welcome.
Seeing no further questions, that completes the hearing on House Bill 986. Thank you for your time.
Thank you.
Thank you, Delegate. And we're going to go to House Bill 771, which is Health Occupations, Human Trafficking Awareness Training. Delegate Miller. Welcome.
Where's your water bottle?
Can I bring my panel?
Yes, please. I think you have Nikki Thrash, Nick Steigerwald, and Jody Finkelstein.
How are you?
Good.
Okay. Good afternoon, Madam Chair and members of the Health Committee. For the record, I am Delegate April Miller, representing District 4, Frederick County, and I am here to present House Bill 771. Human trafficking is not a distant problem, it is a Maryland crisis. Because of our location along the I-95 corridor, our state serves as a major hub for both sex and labor trafficking. Between 2013 and 2024, 1,345 child sex trafficking cases were reported in Maryland. There's also some underreporting. In 2021, while Maryland had the 13th highest signal volume to the National Human Trafficking Hotline, only 16 reports came from medical professionals. This represents a staggering missed opportunity for intervention. Research indicates that up to 88% of trafficking survivors had sought medical care while being actively exploited. This means our healthcare providers are often the only professional contact a victim has outside of the control of the trafficker. The clinical setting offers a rare moment of physical separation between a victim and an exploiter. House Bill 771 provides the training necessary for providers to move beyond treating symptoms to identifying the person. And studies show that after brief educational interventions, healthcare provider confidence in identifying victims jumps from roughly 13% to nearly 40%. Trained professionals look for indicators of control, such as a patient who is not in possession of their own ID or a companion who insists on interpreting for the patient. While sex trafficking is frequently discussed, 14% of healthcare identified cases do also involve labor trafficking. And House Bill 771 ensures providers can recognize signs of forced labor, which are often masked as workplace injuries or chronic neglect. The power of a single informed provider cannot be overstated. Consider the following success story. In one case, a clinician noticed an interpreter becoming hostile when asked to leave the room, and by insisting on a professional language line, the clinician created a safe space. The patient, feeling secure, disclosed the threats of violence. Together, they contacted the national hotline, leading to the patient's rescue. House Bill 771 does not create an unfunded mandate. Instead, it leverages the University of Maryland Safe Center to provide free education. The training mentioned in this bill is free of charge. We're not asking professionals to pay more for credits. We are simply making life-saving information accessible. Crucially, this training is also an optional credit. It allows health professionals to satisfy their existing continuing education requirements while learning a skill set that could save a life. It integrates seamlessly into their current licensing cycle. And the curriculum ensures providers do not accidentally re-traumatize victims, which is a major barrier to survivors seeking future medical help. The bill also requires communication and outreach by the boards to raise awareness of the issue of the medical treatment of victims of human trafficking and the opportunity for healthcare providers to use the course for continuing education credits. I submit to the committee a clarifying amendment on the regulation aspect that will make implementation faster and easier for the licensing boards. And Maryland would not be alone in this effort. States like Florida, Texas, and Michigan have already implemented similar CE requirements for health professionals, leading to a documented increase in victim identification and a more robust multidisciplinary response. By passing House Bill 771, we are ensuring that when a victim walks into a Maryland healthcare setting, they aren't just seen, they are recognized. We are turning our healthcare system into a front line of defense against exploitation. I urge a favorable report on House Bill 771.
Thank you, Delegate. Who would like to go next?
Sure, of course.
Hello, my name is Nikki Thrash, and I serve as the Executive Director of Hartley House, Frederick's only provider of comprehensive services for survivors of intimate partner violence, sexual assault, child abuse, and human trafficking. Hartley House also co-sponsors the Frederick County Human Trafficking Task Force and houses one of Maryland's first child trafficking regional navigator programs. Our program has helped set statewide standards for identifying and supporting trafficked youth. One critical lesson that we've learned is this: the safety net is only as strong as the least prepared link. We at Hartley House have trained schools, law enforcement, first responders, and even banks and hotels. But one sector remains largely untrained. That is healthcare professionals, the very people who see trafficking victims more than any other group. As Delegate Miller stated, a national study has found that more than 81% of trafficking victims were seen by a healthcare provider, yet fewer than 5% were recognized as victims. The gap has devastating consequences. In Frederick County, a 15-year-old trafficking victim was taken to multiple medical offices over several days. She presented with injuries, a sexually transmitted infection, and an adult guardian who would not let her speak or be examined alone. The staff recognized that something was wrong, but the only action they knew to take was to call the National Trafficking Hotline. That alert did reach our team 1 month later. By then, she had been taken out of state. That 15-year-old child has not resurfaced since. With proper training and clear local protocols, that child could have been kept in the exam room longer. Local law enforcement could have been called. She could be safe today. Our request is simple. Give Maryland medical professionals the tools and training they need, not only to recognize trafficking, but to act safely, quickly, and locally. Healthcare workers are often just another set of hands that these victims are passed through. This bill gives them the chance to become the hands that lead the victim to safety. And I need to close with the words of Maya Angelou. Do the best that you can until you know better. Then, when you know better, do better. This bill ensures that our healthcare providers can do better because they will finally know how. Thank you.
Thank you. Okay, thank you, sir.
Good afternoon. Thank you all for the time, and thank you, Delegate Miller, for bringing this bill. My name is Nicholas Steigerwald. I am the Director of Development for Turnaround, Inc. Turnaround is a designated rape crisis center and comprehensive domestic violence organization for the greater Baltimore region and a statewide human trafficking service provider. Our CEO, Amanda Rodriguez, also serves as the co-chair of the Legislative Committee for the Maryland Human Trafficking Task Force, which was formed in 2008. The task force has helped facilitate the recovery of thousands of survivors and the prosecution of hundreds of traffickers across the state of Maryland. I'd love to share a story from one of our survivors that shows why this legislation matters. This survivor came to us at Turnaround after being trafficked beginning at age 18 by a man she met online. She believed he was helping her to enroll her in a certification program in Baltimore. Instead, she was beaten, sexually assaulted, and forced to perform commercial sex acts multiple times a day with different men in hotels across Maryland. She was taken to a local hospital 6 times before police finally identified her as a trafficking victim. Each time she presented with sexually transmitted infections, bruising, and injuries consistent with repeated sexual assault. At one of these visits, a doctor told her she needed to stop being so promiscuous because her injuries were so severe that she may never be able to have children. No one asked if she was being trafficked. No one asked if she was safe. She later told us, if someone had just asked me the question, I would have told them. I could have been spared another 1.5 years of abuse if someone had just asked. This legislation ensures that professionals who encounter survivors are better equipped to recognize the signs of trafficking and respond with care instead of judgment, and to just ask. It creates the opportunity for survivors to feel seen, believed, and protected before harm continues. For these reasons, on behalf of the Maryland Human Trafficking Task Force, Turnaround, and the survivors we serve, we respectfully ask for a favorable report. Thank you for your time and your consideration and for protecting Maryland's most vulnerable citizens.
Thanks. Good afternoon. My name is Jody Finkelstein, and I'm also here on behalf of the Maryland Human Trafficking Prevention Task Force. We are wholeheartedly in favor of House Bill 771 for all the reasons already cited. I can't emphasize the importance of this bill for continuing education and outreach for the education community. It not will only help all of these professionals understand what survivors and victims of human trafficking go through, but as been previously stated, it will certainly help all of the victims in our state, and I know that our state is dedicated to helping all victims, human trafficking included. Thank you so much, and I urge your favorable report.
Thank you for your testimony, for being here today. Are there any questions for this panel? Okay, you made the case very well, but I have a question. Lots of favorable written testimony here, and none unfavorable. But there are a couple of entities that are looking for some amendments. The Board of Physicians, MDH, a couple of others as well. Are you willing to work with them, see if we can't get this good bill into a better place?
Absolutely, yes. And I
Okay.
trust the committee and the committee process to be able to do that. But happy to work. I've already have some amendments that I've kind of redlined into the bill a little bit, so absolutely.
Okay, super. And we have those? Do we have?
I will submit them all to you, yes.
Let's make sure
Yep,
we get them.
Of course.
Great. Thank you so much. Thank you for bringing us this bill. And
Thank
that
you.
concludes the hearing on House Bill 771.
Thank you, Madam Chair.
And we are going to House Bill 489. This is Delegate Kerr. Welcome back. Electronic health records, networks, and electronic medical record vendors of nursing homes. release of records fees. And on your panel, Delegate Kerr, you have Steve Holt.
That's correct, Madam Chair. Thank you. And good
Thank you.
afternoon, Madam Chair and members of the committee. I'm Delegate Ken Kerr. I'm here today to present House Bill 489. In 2023, the Maryland General Assembly passed Senate Bill 684. Here in this committee, we passed House Bill 786 and sent it over to the Senate, but as often happens, the Senate bill came back and ours did not. At that time, the bill, Electronic Health Networks and Electronic Medical Records Vendors of Nursing Homes Release of Records, it allowed nursing homes to direct electronic health networks or electronic medical record vendors contracting with nursing homes to release patient records or electronic healthcare transactions to third-party business associates of the nursing homes. What this bill does today, 489, simply seeks one thing: to allow electronic health network or electronic medical records vendors to charge reasonable fees for the release of these patient records to third-party business associates of nursing homes. The bill preserves the reasonable requirements that were in the 2023 bill, House 648, Senate Bill 648, to facilitate and encourage information sharing. But it allows the companies that use their capital, their innovation, to recoup some of the investment in electronic health record systems and networks by charging reasonable fees for their time, effort, and maintenance of the technology required to share this information with the third-party business associates. Just as other commercial ventures do when providing important services, the companies that have developed continue to maintain these electronic record systems and continue to constantly innovate and improve and evolve to keep pace with new technologies while working to ensure that their products keep up with the dynamic needs of healthcare providers and patients. This bill simply allows companies to charge reasonable fees when other entities use information from their proprietary system. The reasonable fees discussed here do not apply to the residents of the skilled nursing facility or the skilled nursing facilities themselves. So with that, I would like to ask you for a favorable consideration of House Bill 489, and I will now turn it over to Steve.
Thank you. Good afternoon, Vice Chair Colson, members of the Health Committee. Thank you for the opportunity to be here today in support of House Bill 489. My name is Steve Holt, Vice President of Government Affairs with Point Click Care. We are a leading technology partner to providers offering clinical solutions to deliver the best care possible for patients and residents. We offer our services across all 50 states and are a market leader serving skilled nursing in Maryland. House Bill 489 makes a targeted and necessary correction to existing law by restoring the ability of electronic health record vendors for skilled nursing to charge reasonable fees to third-party business associates of those facilities for access to proprietary technology systems, interfaces, and infrastructure. House Bill 489 does not roll back information sharing, weaken patient protections, impact care delivery, or reduce transparency. It does not charge residents or their representatives for access to their health records for any reason, and it does not place additional economic burdens on skilled nursing facilities. Instead, it aligns Maryland law with longstanding market principles and federal policy by ensuring that companies that invest in building, maintaining, and securing complex technology systems can continue to operate and innovate in a fair marketplace. The current law is not that. EHRs supporting skilled nursing are uniquely barred from recovering costs from third-party businesses, regardless of access, volume of requests, or purpose. EHR systems are not static products. They must continuously invest in cybersecurity, interoperability, provider-requested upgrades, and compliance. Prohibiting reasonable fees between third-party business associates undermines the resources necessary to sustain these mandates. Across healthcare, financial services, and telecom, access to proprietary infrastructure is governed by commercial agreements that recognize cost recovery and risk. Fees and unfettered access between commercial entities to this infrastructure is not the norm in any industry, and Maryland prohibition does not exist anywhere else in the nation. In conclusion, 489 restores balance by allowing reasonable negotiated fees between commercial entities. It's a narrow corrective measure that restores fairness and supports competition. For that reasons, I respectfully urge a favorable report.
Thank you. Thank you for your testimony. Are there questions from the committee? I'm going to go to Delegate Kipke first and then Delegate Gazzoni.
Thank you, Madam Chair. To the gentleman who just spoke, there's a lot of opposition to this bill. I'm curious if you'd looked through the opposition and if there's anything that you'd like to say to directly respond.
Certainly. The piece that we'd really like to focus on here in front of you is the extremely narrow scope of this bill. I think when you read through some of the opposition, it conflates what this House Bill 489 is trying to accomplish. For example, it does not impact patients or their families or their representatives from accessing their medical records. This is purely a relationship between a third-party electronic health record or medical system, the skilled nursing facility, and another third-party vendor business associate of that skilled nursing facility. So this doesn't impact the clinical teams or those aforementioned groups like the patients themselves, their families, or any of their representatives. Additionally, it doesn't impact CRISP. It doesn't impact the health information exchange within the state of Maryland or the ability of the Medicaid agency to be able to access that information as well. So I think narrowing in on the focus of this bill is critically important. And the other piece that I would add to that is when we talk about good public policy, this prohibition on fees does not exist anywhere else in the healthcare ecosystem. It does not exist for hospital EHRs. It doesn't exist for ambulatory setting EHRs. It doesn't exist for primary care physicians, specialists. So what makes skilled nursing facilities so unique that this supposed good public policy must exist when it does not in any other aspect of the healthcare ecosystem, not only in Maryland, but nowhere else in the country does language like this exist.
Could I ask a quick follow-up? Yes. Thank you. Who pays you now?
Please repeat yourself, sorry.
Who pays you now?
The entity that I am with, Point Click Care, we are directly contracted with the skilled nursing facility.
So the skilled nursing facilities?
Correct.
Right? So when you receive payment from them, does the company not take into account the total breadth of the work that you're going to need to do? I mean, how is the cost that you charge the skilled nursing facilities isolated from the fact that you're going to have these other inquiries?
So when you think about how and the issue that this bill is attempting to rectify, our direct contract with the skilled nursing facility, if that skilled nursing facility has contracts with other third-party vendors, we don't know that those third-party vendors exist. So there is no way up front to be able to deliver a price.
Couldn't you ask as a part of the application process? Couldn't you ask?
We could, but that would not limit what they are able to access within the nature of the language as it exists today.
Thank you.
That Delegate Kipke asked the question that I was thinking of, because my understanding is that Point Click is, is contracted with the nursing homes, and the nursing homes are paying them. So it seems, I think I was in the same place with Delegate Kipke. So thanks for those questions, Delegate.
May I respond?
Your question?
Just to reiterate, this is a relationship that exists outside of the nursing home Point Click Care relationship that we don't have oversight over. And so we are not able to understand where these inquiries or requests for information are coming from. That is why in any other care setting, you would have contractual relationships between the external vendors that are accessing the electronic health record or the electronic health network.
Okay, and yet the nursing homes own the data.
They do own the data.
You're housing the data for them.
That is correct. But when you look at any industry that has a system of record or data sets that fall within other corporate entities, there are fees attached to that. And when third-party vendors access that data for their own profit outside of the skilled nursing facility, it is reasonable, in our belief, and what we are asking the committee here today, to allow fees for those data transactions.
Aren't they accessing that data specifically for the benefit of the nursing?
We can't speak to all third-party vendors. That's what we're trying to add specificity to this the law that exists as it is today.
And the nursing homes provide you with information about who they have contracted with to access the data, correct?
We do not know that information. This is a third-party relationship that we are not aware of. That is why when you think about cybersecurity and risk, that is why we need contracts with these other vendors to be able to charge a fee and understand who they are.
Okay. And can you explain how CRISP is involved in this? Because I think that they have a role
They're
in this
not.
also.
I wanted to reiterate, CRISP is not impacted by this.
Okay.
Okay. Okay. Seeing no further questions, thank you for your testimony. Thank you, Delegate, for the bill. And I'm going to call an unfavorable panel. Kirill Resnick, welcome to this room. Brian, he used to be here, so. Brian Brown, Dana Kaufman, and Ashley Bagwell. Kirill, you want to go ahead?
Vice Chair Collison, before I begin, Dana Kaufman is not going to be testifying.
Okay.
Good afternoon, Vice Chair Collison and members of the committee. I'm Ashley Bagwell here this afternoon on behalf of Lifespan Network, respectfully in opposition to House Bill 489. As Delegate Kerr said, this issue was a part of a bill that this committee and the General Assembly took up in 2023. And at that time, Lifespan supported the bill specifically because it included a prohibition on charging fees to nursing homes. Absent a clear public purpose on removing that prohibition, we must oppose this bill. I did want to reference comments that the previous panel made about how this bill doesn't include charges on nursing homes, just by pointing to the fiscal note on the bill under small business effect. It specifically says small business EHNs or EMR vendors may collect fees from a nursing home. So that is the reason that we're opposed to this bill. Thanks for the opportunity to testify, and we urge a favorable vote. Unfavorable. Sorry. Thank you.
Thank you, Madam Chair, members of the Health Committee. I almost said HGO, members of the Health Committee. Old habits die hard. My name is Kirill Resnick, and I'm here representing Real-Time Medical Systems, a data analytics firm working with CRISP, our state's HIE, and our state's nursing homes to help reduce hospital admissions, creating better health outcomes for seniors and reducing costs to Medicaid. We are here in strong opposition to HB 489. As has been previously mentioned several times, 3 years ago, this committee passed HB 786 and SB 648, a bill that authorized the release of nursing home records. During that effort, the committee rejected amendments to do just what this particular bill is asking you to do. And now they're back again 3 years later trying to get satisfaction in what they couldn't achieve 3 years ago. As you know, medical records are actually owned by the patients, not by the nursing homes, not by the EHRs, but by the patients. EHRs license their database software to nursing homes at significant cost, money that is almost exclusively paid by taxpayers through Medicaid and Medicare. Now, EHRs want to be given the ability to charge to release that data, again, that they don't own. They want to get paid both on the front end and the back end. And this double dip is substantially paid, again, by taxpayer money. The amount an EHR can charge is unlimited. Despite the talk about reasonable fees, there is nothing in this bill that limits fees. They can charge thousands of dollars per chart. Families and patients would be stuck with a monopoly controlling the data that the patients own themselves. We at Real-Time utilize this data as a vendor to CRISP to analyze and feed back actionable information to nursing homes within hours of their recordation. The real-time analysis last year has led to 32,000 recommendations to nursing homes for patient care, resulting in what a University of Maryland study determined was a 52% reduction in hospital admissions. Any delay in getting this data can have significant and harmful consequences. There are other additional reasons why we believe this legislation is inappropriate, a slippery slope for other EHRs to begin charging, and a potential investigation coming out of the Department of Justice under the 21st Century CARES Act, which we believe that the Department of Justice and the Federal Trade Commission are currently investigating. For all of these reasons, we urge a strongly unfavorable vote, and I'm happy to take any questions. Thank you.
Thank you for your testimony. Delegate Gazzani.
So I'd like to go back to the CRISP aspect of this.
Sure.
Can you tell it, because if you could just explain how CRISP fits into this whole process.
Absolutely. So CRISP, as you know, is our state's health information exchange. Though they are exempt, we as a vendor to CRISP are not. And so to us, this would be an incredible cost that would then be added to the cost to the state. Our vendor contract with CRISP comes from money that comes out of the state budget.
Thank you.
Seeing no other questions, that completes the hearing on House Bill 489. Thank you very much for your time and your testimony today. And we are going to go to House Bill 995, Health Occupations, Behavioral Health Care Providers, Use of Artificial Intelligence. Delegate Woods, welcome back.
Hello.
We're going to make this a regular occurrance.
It seems like I just saw you all.
You did, less than 24 hours ago.
Less than 24 hours ago. I'll have my panel come up and join me. Is Christine here?
I saw her. There she is.
And Seacon, and Christine Crown, okay?
And you said 3 people?
Yes.
I didn't hear you, I'm sorry.
Okay.
All right. Well, good afternoon. In absentia, Chair Bagnall, to you, Vice Chair Cullison, and to the esteemed members of, as I said yesterday, my first love, the Health Committee. It's good to be back with you. For the record, I am Delegate Jamila Woods, and I'm here today to request a favorable report on House Bill 995, legislation to establish clear guardrails on the use of artificial intelligence in behavioral health care. Technology is evolving rapidly, as we all know, and artificial intelligence is increasingly being integrated into healthcare systems. While innovation can improve efficiency, we must be extremely cautious when it comes to behavioral health. Mental health treatment is deeply personal. It requires trust, clinical judgment, ethical responsibility, and human connection. House Bill 995 ensures that artificial intelligence does not replace that human relationship. This bill draws a clear line. It prohibits behavioral health care providers from using artificial intelligence to provide behavioral health care to patients. That includes assessments, diagnoses, treatment, counseling, development of treatment plans, case management, and therapeutic communication. In other words, AI cannot conduct therapy. It cannot make clinical decisions. It cannot replace the provider's judgment in interactions intended to diagnose, treat, or emotionally support a patient. At the same time, HB 995 recognizes that providers may use AI for limited administrative support tasks. This bill permits the use of AI for functions such as scheduling appointments, managing billing and records, organizing notes, or analyzing operational data. However, even in those circumstances, the provider must ensure compliance with federal and state confidentiality laws, sign agreements to protect patient information, and ensure that protected health information is not used to train the AI system. The provider must also independently review any reported data generated by the system to ensure accuracy. Importantly, the bill requires transparency. If a system that employs artificial intelligence could materially affect clinical decision-making or patient-facing services, the provider must obtain written, informed consent from the patient. Patients must also receive written and verbal notice if AI is being used for administrative tasks and be informed of potential risks, including the possibility of a breach of confidentiality. Behavioral health patients often share the most vulnerable thoughts, trauma histories, and emotional struggles. The idea that these interactions could be analyzed, sorted, or processed by artificial intelligence systems without clear consent and oversight raises serious ethical concerns. This legislation prioritizes patient autonomy, confidentiality, and the integrity of the therapeutic relationship. House Bill 995 does not prohibit the dissemination of self-help or educational materials. It does not block innovation. It does not. Instead, it ensures that innovation does not outpace ethics, patient safety, or professional responsibility. This bill affirms a simple principle. Technology may assist, but it must not replace the human care that behavioral health treatment requires. For these reasons, I respectfully urge a favorable report on House Bill 995. Thank you so much for your time and for your consideration. Who wants to go first? All right.
Good afternoon, Chair and members of the House Health Committee. My name is Caressa Proctor, and I serve as the Executive Director of the Maryland chapter of the National Association of Social Workers, and I represent almost 3,000 social workers in our Maryland chapter alone. Our membership reflects a full breadth of the profession. We represent clinicians providing direct therapy, social workers leading community-based programs, administrators overseeing large systems of care, policy advocates shaping legislation, and scholars. My own work really sits at the intersection of administration, community organizing, and legislation, which means I'm not currently an LCSW-C, which means that I cannot diagnose or treat clients in Maryland. That limitation in my own work exists to protect the public. It ensures that those providing clinical care meets rigorous education, training, supervision, and ethical standards. If someone with a bachelor's and a master's degree in social work cannot diagnose or treat clients without that credential, neither should artificial intelligence. Let me be clear, we are not seeking to eliminate AI. We believe that artificial intelligence has a place in administrative efficiency, research, and certain supportive tools. But innovation without guardrails puts both practitioners and the public at risk. This legislation really provides necessary guidelines to ensure that AI is used responsibly, ethically, and safely within behavioral health systems. Social workers can handle some of the most sensitive information imaginable: trauma histories, mental health diagnoses, substance use treatments, and more. We really must ensure that this information is not entered into open AI systems where confidentiality, data ownership, and secondary use of data cannot be guaranteed. Protecting client privacy is not optional. It is a foundation of our profession. Consumers deserve the same empathy, discernment, and ethical accountability that only a human being can provide. Our ethical standards are why we are guided on this position. So without those clear standards, we might not have proper client care, which has led to already several deaths among our community. Regardless of this legislation outcome, this case underscores what the stakes are. Thank you.
Good afternoon, members of the Health Committee. My name is Christine Crone, here on behalf of the Greater Washington Society for Clinical Social Work. The Greater Washington Society for Clinical Social Work was established in 1975 to promote and advance the specialization of clinical practice within the social work profession. Clinical social workers are licensed to evaluate, diagnose, and treat mental disorders, treat substance use and addictive disorders, and practice as licensed medical professionals. Through lobbying, education, community building, and social justice activities, the coalition affirms its commitment to the needs of the social work professionals, the needs of their clients, and the broader community. House Bill 995 addresses emerging issues in behavioral health care by ensuring artificial intelligence is not used in place of direct human clinical services, prohibiting behavioral health care providers from using AI for assessment, diagnosis, treatment planning, and case management, and authorizing limited use for administrative tasks. Clinical social workers emphasize the therapeutic relationship, that human connection, empathy, nuanced understanding, and trust. It's foundational to effective behavioral health care, and AI cannot replicate clinical judgment or relational engagement. House Bill 995 safeguards the human core of care while allowing technology to reduce the administrative burden. With that, the Greater Washington Society of Clinical Social Work supports House Bill 995 and urges the committee to give this a favorable vote. Thank you.
Good afternoon, Madam Chair, members of the committee. I'm Ann Seacott with Public Policy Partners. I have a couple of clients that are strongly in support of this legislation, including the National Association of Social Workers, also the National Council on Alcoholism and Drug Dependence. And so wanted to make it clear that while this bill has been brought forth by two of the major social work associations, the bill is written to all licensed behavioral health providers in the Health Occupations Code. And so from the substance use disorder perspective, obviously in those kinds of programs and treatment programs, there are licensed professional counselors, there are social workers, there are licensed drug and alcohol counselors, so it would cover the gamut. We have been reached out to by numerous impacted stakeholders with lots of questions about all of this. And so we are absolutely, with the sponsor, working on some amendments to address and mostly clarify things. It's been said this is about putting the boundaries on what can't be used. Frankly, I think we attempted to list in the bill what AI could be used for, and I think that we are leaving things out, so I think we might just be talking about what those limits are instead of what is permissible. We think that that probably fits better, especially as technology continues to evolve. We also know we want to do some clarifying on the consent process. We don't want the written informed consent piece to interfere with the use of telehealth. So we want that we want this to be built into existing consent processes and things like that. So, so this is just to say that we are in full support of making sure that some of the horror stories that we hear in the news about AI that is, a tool that for some people can be helpful in providing some level of resource and coaching, but absolutely is not a human being who can do the proper clinical services that someone needs. So with that, we ask for a favorable report.
Thank you. Are there questions from the committee? Okay, I don't see questions. Oh, I do see questions from a committee member. Delegate Lopez.
Thank you, Madam Chair. I think this question might be best for Ann, since you just brought it up in your last remarks. Can you give us, in just very broad strokes, maybe like in a sentence or two, what can AI do and what can't it do in this scenario?
Absolutely. So does the social worker want to answer that instead of the person who pretends to be a social worker?
So your question is what it currently can do and cannot do?
Yes.
AI
in the bill. Yeah.
Yeah.
Oh,
that's what, and like
in
current
the
posture
bill.
of the bill.
Sure. In the bill, it can handle administrative work, i.e., let me go back so I can make sure I'm reading it all to you correctly. It can schedule appointments, manage billing and records, organize the notes of the clinical person, analyze operational data. We do not want AI to provide clinical diagnoses. We do not want AI to do assessments. We do not want AI to create treatment plans, because those are individual. They should not be done across the board, and they should be done by someone who has the empathy, the understanding, and understands the person that they're dealing with.
Gotcha. So the same way that we as lawmakers use AI to, schedule your calendar, take notes,
Correct.
that type of thing. Okay, thank you.
My pleasure.
Thank you, Madam Chair. So I'm assuming that part of this has to do with the sort of chat bot kind of things, where
Correct.
people can really have a conversation with what may seem like a person, but it's not actually a person. Is that sort of what you're really trying to aim at here?
That is correct. And as was previously stated by two of the panelists, we have seen where that can be both beneficial but also detrimental, because sometimes these systems tend to side with the individual and encourage them to do things that are detrimental to them as opposed to helping them.
Thank you.
Thank you, Delegate. Delegate Johnson.
Thank you, Madam Chair, and thank you, Delegate, for the bill. I was reading John Hopkins, their opposition to the bill, and they say the bill, they use AI by focusing on predictive analytics for suicide.
I'm sorry, I can't hear you. My apologies.
How about now?
It's a little better.
I was reading the opposition from Johns Hopkins University, and they said they use AI by focusing on predictive analytics for suicide risks, digital monitoring for cognitive decline. Under the bill, would they still be able to use AI for those purposes?
They use AI for, I heard cognitive.
Focusing on predictive analytics for suicide risk and digital monitoring for cognitive decline.
I would prefer to have a conversation with them before I attempt to answer that question for you. I don't want to say the wrong thing.
Oh, okay. All right. Thank you. Thank you.
And we, as was previously stated, we are planning, actually scheduling meetings with people who have concerns to kind of get that clarification that you heard Ms. Seacott talk about, so that we could be very clear about what we can and cannot do and what would be reasonable and unreasonable.
Okay. Thank you. Thank you,
My
Madam
pleasure.
Chair.
Thank you. So, thank you, Delegate. You just sort of addressed my question. So there's a number of amendments here, and I'm wondering if some of these amendments won't address some of the opposition issues. So I think, I'm happy to hear that you have begun those meetings.
Yes, we're scheduling meetings now to kind of meet and get some clarification. And we'll make the appropriate amendments that we feel would be most reliable in this.
Okay, great. Well, that completes this panel then, and I'm going to call up a panel favorable with amendment, and that's Andrea Mansfield. A panel unto one.
Great. Thank you very much, Vice Chair Cullison, members of the committee, Andrea Mansfield, representing the licensed clinical professional counselors of Maryland. And one, I know our clients, the clinical counselors, they fully support the human kind of review of information and definitely do not think that AI should be making counseling decisions and doing treatment plans for individuals. We have been working closely with the previous panel up here discussing amendments. We've reviewed some. We are continuing to do that. So really, I don't have any amendments in my testimony to put forth because we're working with them on the amendments, and we are happy to continue to do that, working with the sponsor and all other parties to work out the differences and ensure that the bill that we are bringing forth does provide the appropriate protections for patients, but also allows the counselors and other health professions to more efficiently do their jobs and their work every day. So.
Are there any questions for this witness?
Thank you.
Seeing none, thank you very much, and please look forward to working with the delegate. Now going to call up an unfavorable panel. That's Natasha Mayhew and Allison Taylor. Whichever one of you'd like to start.
Hi there, Allison Taylor, for the record, on behalf of Kaiser Permanente, and I apologize to the committee. I accidentally selected unfavorable from the drop-down rather than support with amendments. So we're definitely supportive of this concept, and I would say our amendments fall in the clarifying category, as Ms. Seacott mentioned. So I did reach out to her earlier, and I spoke with the sponsor, and we're happy to work with them. So 8 seconds.
Excellent testimony. Thank you. Natasha, you want to go ahead?
Yeah, good afternoon, Madam Vice Chair, members of the committee. Natasha May here on behalf of the Maryland Hospital Association. In opposition to House Bill 995, while we do support the need to ensure that behavioral health care remains grounded in clinical judgment and the therapeutic relationship with the provider, we believe the bill as introduced imposes an overly broad prohibition on the use of AI in behavioral health care, unintentionally restricting the use of beneficial, clinically supervised technologies. So we are discussing our concerns with the proponents and really thank them for taking them into consideration as they work through the amendments. But again, our concern with the bill as introduced is that it doesn't distinguish from AI that replaces clinical decision-making and AI that supports it as an adjunct tool to improve efficiency while keeping clinicians in control. And these are cases in which it does not replace clinical judgment, but enhances clinical care, which is really important in the ever-evolving state of modern healthcare delivery. So, for instance, AI can play a role in improving treatment planning, formulating preventative interventions, facilitating preventative mental health care. And so we don't want the broad prohibition to impede the quality of care or limit the development or adoption of tools that can enhance accessibility and efficacy of mental health care. And one thing that was pointed out earlier that we also have concern with, and hopefully will also be addressed in amendments, is that the current bill doesn't mirror the telehealth requirements around consent, which the bill requires written consent, and under the telehealth requirements, those that are written or oral. So we look forward to continue working with the sponsor and proponents, but request an unfavorable report on the bill as introduced.
Thank you for your testimony. Are there any questions for this panel from the members? Oh, Vice Chair Cullison.
So I'm sorry if I was distracted, Natasha. Did I hear you say you think that some of these issues can be addressed with the amendments that are being considered?
Yeah, we're consulting with our members to see if at least the amendments that we've seen so far address those issues. So we do appreciate them taking that into consideration and having the continued discussions.
Great, thank you.
All right, seeing no further questions, this does conclude the bill hearing on House Bill 995, and we're going to move to House Bill 975. Wait, no, I'm sorry, 1002. Did you say 10? No, Vice Chair, you said 1002? Yes. To House Bill 1002. This is nursing facilities involuntary discharge or transfer. Delegate Lopez, if you want to go ahead and approach, and you can bring your panel and start your testimony when you're ready.
There we go. And Cornelia. There we go. And then Cornelia, do you want to come up too? Sure. Good afternoon, Madam Chair, Madam Vice Chair, and fellow members of the Health Committee. Thank you for the opportunity to testify today. For the record, I'm Delegate Leslie Lopez of District 39, and I am proud to sponsor HB 1002, a bill that has no opposition and no fiscal note. When a Marylander enters a nursing home, often after a crisis, they deserve stability, dignity, and a clear path forward. Yet today, residents who have lived in a facility fewer than 30 days can be involuntarily discharged with little warning and no guaranteed safe destination. That gap in the law is not just a technical oversight. It's a human risk.
one that too often leads to hospital readmissions, homelessness, or unsafe living conditions. An involuntary discharge is defined in federal regulations as a transfer or discharge initiated by a nursing facility without the consent of the resident or their representative. While Maryland law already outlaws that this can only happen for specific reasons and requires written notice, updates are necessary. Currently, there is a gap for residents of less than 30 days, as well as inconsistencies in how the law is interpreted, including the use of hotels and shelters as short-term housing locations. Such locations are sometimes not safe and are rarely viable in maintaining prescription administration and overall physical and mental health. I'm sorry, someone's talking. I'm having a hard time concentrating here. You will hear from my esteemed sponsor panel about the need and practicality of this legislation in more detail. In short, this legislation offers a practical, compassionate fix. It ensures that every resident receives a 30-day involuntary discharge notice, regardless of length of stay. Currently, only residents who have been at the facility for 30 days or longer receive this notice and time for appeal and coordination. This bill also requires facilities to identify a safe and viable discharge location with a specific address. These are simple standards, aligned with patient safety principles emphasized by the Centers for Medicare and Medicaid Services, but they make a profound difference in people's lives. Good policy is about foresight, recognizing that stability in care transition protects both people and systems. By giving residents time to plan and ensuring accountability in discharge decisions, the bill reduces preventable hospitalizations, strengthens continuity of care, and upholds the basic dignity every Marylander deserves. We have an opportunity to close a harmful loophole and replace uncertainty with clarity, risk with responsibility, and vulnerability with protection. I respectfully ask for a favorable report.
Good afternoon, Madam Chair, Vice Chair, and members of the committee. Thank you for this opportunity. My name is Carrie Craig. I'm the State Long-Term Care Ombudsman. We advocate for the health, safety, welfare, and rights of residents who live in long-term care. And we also investigate complaints made by or on behalf of residents. Last year alone, we resolved almost 4,000 complaints at the direction of the resident, which I think is a really great number. So this bill is really important to the residents that we serve. It provides a critical safeguard by requiring nursing homes to give every resident a 30-day written notice before an involuntary discharge. In Maryland, there's 220 nursing homes, which is over 27,000 licensed beds. So as Delegate Lopez said, this will ensure the safety of residents. It will give everyone time to work together to put together a really good, solid discharge plan so residents can be more successful in the community and they won't end up back in the nursing home. Every resident deserves a safe, secure, and sustainable discharge. And unfortunately, we've had cases where residents are discharged to homeless shelters and yet they have a diagnosis of diabetes and there's no place to store their insulin because it has to be refrigerated, or a resident who the nursing home said will pay for a hotel for a few days and they don't have an income, so after a few days they have nowhere to go. These are not safe or sustainable. This bill strengthens accountability, protects resident rights, and helps prevent unsafe discharges that can have really devastating consequences for residents. So the Office of the State Long-Term Care Ombudsman urges a favorable report in House Bill 1002. Thank you.
Good afternoon, Vice Chair Cullison, members of the committee. Thank you for the opportunity to testify in support of House Bill 1002. And thank you to Delegate Lopez for sponsoring this important legislation. My name is Sarah Westrick. I'm the Advocacy Director for AARP Maryland and a member of the Oversight Committee on Quality of Care in Nursing Homes and Assisted Living Facilities. AARP strongly supports this bill because it addresses one of the most harmful issues families report, that is, residents being discharged to unsafe, unsuitable, or unprepared locations. This bill ensures a resident may only be discharged to the specific location listed in the written notice, and only once the receiving facility confirms it can safely accept them. This prevents inappropriate discharges to shelters or other temporary locations that do not have adequate support. The bill also modernizes the state's discharge notice requirements. Standardized notices will provide clear, complete information, including contact information for the ombudsman. Requiring updates and 30 days notice ensures transparency and protects residents from abrupt and destabilizing moves. The bill further strengthens post-discharge planning because it requires a detailed plan developed with the resident, their care team, and representative when appropriate. This helps ensure residents transition to safe, stable, and medically appropriate settings. Involuntary discharge is one of the most traumatic experiences a nursing home resident can face. House Bill 1002 provides urgently needed safeguards, and this is why AARP Maryland respectfully urges a favorable report. Thank you.
And we've got one more addition to our sponsor panel.
Greetings, Chair Bagnell, Vice Chair Cullison. My name is Cornelia Bright Gordon, and I'm from Maryland Legal Aid. And it's nice to appear before you again. In addition to myself, Mr. Clayton Foley, one of our clients, will be testifying virtually. When you all call him, he's waiting. As you know, Maryland Legal Aid is a nonprofit law firm that provides free legal services to low-income and vulnerable Maryland residents. We represent hundreds of nursing home residents. Regularly, we're in the nursing homes weekly and daily, weekly, monthly, and our clients rely on the nursing facility to keep them safely housed and to maintain their dignity. House Bill 1002 is an important bill that will save lives. It ensures residents receive adequate notice and meaningful time to plan. 30 days notice is generally required before a resident can be evicted from a nursing facility. Nursing facilities sometimes use the weak language in existing law to make last-minute changes to the locations. Sometimes, in the most egregious violations, send our clients to unsafe settings like homeless shelters and one-night cheap hotels. One of my clients, unfortunately, was sent to a nursing facility, and we didn't know it, and she was rolled out on the sidewalk, and there she died. We were in the middle of an appeal. Of course, I had to dismiss the appeal. It was a tragedy. Closing the loopholes that allow residents' destinations to change is critical for our clients. Delegate Lopez is aware that we have offered a friendly amendment, which you all have as well. We ask you for favorable support on House Bill 10002. Thank you.
Thank you for your testimony.
Chair Bagnell, members of the committee, for the record, my name is Dana Kaufman. I'm here today on behalf of Lifespan Network. We were support with amendments, and these amendments have been discussed with the long-term care ombudsman, which I appreciated her sitting down and talking with us, and we've shared these with the sponsor as well. Unfortunately, involuntary discharge does occur, and it is necessary in certain circumstances. I do want to emphasize, though, if a nursing home violates the safe discharge law, then they are subject to enforcement and penalties and actions. And we would strongly support those actions and urge the state to take those actions. What this bill does, though, is it does strengthen and it makes sure that the protections are given to all residents despite their length of stay in the nursing facility. And it also does ensure that a facility that is going to take them is aware of them and accepts them. It is not easy to place a resident in a nursing home to another location. I'm sure you can kind of imagine that. So we do support the bill, and we look forward to having some continuing discussions on the amendments that are part of my testimony that we proposed. Thank you.
Thank you for your testimony. I see I have a question from Delegate Hutchinson.
Thank you, Madam Chair. Maybe the delegate, but thanks for the bill. This obviously is an issue that you brought forward. Can you give me more like examples to explain the significance of this? I heard the story about the one person going
Sure.
outside, but
Yeah.
put this in context for me as to what happens and
Sure. So I'm happy to do it. It might make sense for our ombudsman to answer that because she is entrenched in this space and can come up with more than just the hypotheticals that I have I've come across. Go for it.
Thank you. Involuntary discharge is the #1 complaint that we receive in our office every year. And it's the #1 complaint across the country. So residents, they can be involuntarily discharged for 6 reasons. Just a small number of reasons. But what happens is, what we see in our office, residents are discharged to locations that they don't know. We've seen homeless shelters, hotels, storage units, condemned houses, and they're not given the time to create a really good, solid discharge plan, especially if they don't receive the 30-day notice and they haven't been in the home for 30 days. So it ends up being, we don't even receive those complaints. So there's a whole bunch of residents who are getting involuntarily discharged without even receiving notice because they haven't lived in the home for 30 days. And we don't actually have data on that because nobody receives those notices. We receive the notices to the Long-Term Care Ombudsman Office for those residents who are involuntarily discharged who actually received the 30-day notice. So all of our data, all the complaints that we've received, over 250 last year, were from residents who had been in the home for longer than 30 days. And what's so traumatizing about this is those residents, that's their home, and then they're told they have to leave, which is terrible in the first place. They're used to their schedule, they're used to the staff, they have friends who they consider family, they consider the staff family, and then they're told they have to leave and go to a new place, and they have to wrap their head around what that's going to be like, and then feel like they're not wanted at their home, and then go to a new one. And it's just, the whole situation is very traumatizing. In the Long-Term Care Ombudsman Program, our local ombudsmen work really hard to work with homes and to get on top of situations before the discharge notices are given. But it's a real big issue.
thank you.
Are there any other questions? Oh, Delegate Gazzoni.
Yeah, I just, so I think what you were just, the ombudsman was just saying is for the people that don't even make it through their first 30 days that are involuntarily discharged prior to that, you don't necessarily have a whole lot of data on that?
We don't, because they don't have a right to this 30-day notice. So we want to change the statute saying that all residents have a right to a 30-day notice.
Okay.
Which, with those 30-day notices, the Ombudsman Program, per federal regulation, has to be notified the same day the resident is given the notice.
So presumably that means you would be able to help prevent it or
yes,
ensure that things go well. Okay, great. I got it. Thank you so much.
Delegate Riley.
Thank you, Madam Chair. Yeah, you may have mentioned this. I'm sorry I was a little late in another bill hearing, but what I don't understand, so why are they being discharged involuntary? What are some of the reasons why within that time frame?
There are 6 reasons. I might not say this right.
Okay.
6 reasons.
Okay.
If they don't meet level of care, if the home closes, if they're for non-payment, the health and safety and the welfare of the other residents are in jeopardy. That would, but I kind of think that would be more of an immediate type of issue. Oh, yes. If the home can't meet their needs, I think I'm on 5 or 6. There's 6 of them.
Okay.
Those are the reasons why a nursing home can involuntarily discharge a resident.
Okay, and this bill would address even those issues?
So this bill will make sure that every resident gets a 30-day notice because it really takes longer than a day or two to come up with a good, solid discharge plan. And what we're seeing is if residents don't have that really good discharge plan, They end up in the community without the services they need. They can't be successful. They go back through the emergency room and then back into the nursing home, and nobody wants that.
Thank you very much. Thank you, Madam Chair.
Thank you. I know, Dana, you had spoken to amendments that you were working through with the sponsor. But Delegate Lopez, there was also an amendment from Maryland Legal Aid, which I think your witness spoke to, and you're good with that amendment as well.
Yeah, we've started conversations to come up with consensus, as is the protocol for this committee. So I'm confident we'll get there with a few more, email exchanges and talks.
Great, thank you very much. Sure. Oh, Delegate Johnson.
Thank you, Madam Chair, and thank you, Delegate, for the bill. So you mentioned one thing about this is their home. So we have other Maryland laws about residence and evictions that they require at least a 30-day written notice. So does this not fall under any of the existing laws that we have for evictions?
No, because it's a facility.
But it is their home, it's their residence.
There's probably a legal answer that's better than what I would come up with, so Go for it, please, Cornelia, take it away. Do your magic.
Delegate, I think you're referring to the landlord-tenant laws.
Yeah, we do have landlord-tenant laws.
And we have
That's correct.
a lot of landlord-tenant protections and laws. These are not tenants. These are residents in a medical facility. And so the landlord-tenant law doesn't apply. It's a whole separate set of rules and federal law that's consistent across the whole country.
Okay. All right. Thank you. Thank you, Madam Chair.
Seeing no further questions, this concludes the testimony of this panel. Thank you very much for your testimony. And we do have a favorable panel, Megan Peters and Clayton Foley, who is virtual. You can go ahead and come to the table and start your testimony, and we'll bring up Clayton Foley as well.
Good afternoon, Madam Chair, Madam Vice Chair, members of the committee. My name is Megan Peters. I'm the Director of Government Affairs for the Alzheimer's Association, here in strong support of House Bill 1002. For people living with dementia, stability and predictable care are important. Any abrupt or poorly planned care transition can cause confusion, distress, decline, or even hospitalizations. And that's why the Alzheimer's Association is invested in strengthening care protections, including around those with nursing home discharges. You heard from the previous panel what the bill does, and I will just highlight from a dementia lens for a person living with dementia who may need more time to adjust and who cannot advocate for themselves. This 30-day notice and additional discharge planning requirements is not just procedural, but a matter of protecting well-being. House Bill 1002 is a vital step towards strengthening care transitions, protecting our nursing home residents and families who are dealing with a very devastating disease. For these reasons, we urge a favorable report. Thank you.
Thank you for your testimony. Mr. Foley, if you want to unmute and begin your testimony.
Still muted.
The show is unmuted. Yeah. Mr. Foley, you can begin your testimony. We can hear you.
Can you hear me?
We can hear you.
Yes, ma'am. My name is Clayton Foley. I'm a 55-year-old quadriplegic. I have been in a complete care, Corsica Hills for the past 23 years. I consider this my home. Unfortunately, in 2025, I was evicted from the facility with notification. They listed 8 possible discharges. None of those facilities wanted to take me or had the medical needs to provide for me. I did an appeal notice of the eviction. It was affirmed by a judge. Every day that I'm here, I worry that the knock on the door is going to tell me that in 2 days that I have to leave the facility. every day that I worry that a staff member, the knock, social worker, the knock, the administrator, the knock, that I'm going to have to figure out how to get to another nursing home or another facility in less than 48 hours. This bill would provide me more, how would you say? Oh, that's a knock on my door. More stability and knowing exactly where I'm going to go. I believe this bill is very important for patients like me. Like I said, I'm a quadriplegic. My care needs are very complicated, and most facilities aren't capable of doing my care. Thank you.
Thank you for your testimony. Are there any questions from the members for these witnesses? Yes, Vice Chair Cullison.
Thank you, Madam Chair. Mr. Foley, if you're comfortable, can you tell me why you were evicted from where you had been for a number of years?
Yes, ma'am. I was evicted because they said I was unsafe to the other residents because I approached my administrator with my electric wheelchair and confronted her about something. I'm not dangerous. I've never hurt anybody. I've never been a threat to any resident or staff. As you see, I'm a quadriplegic. There's nothing really I could do to anybody except have a really big mouth.
Thank you for sharing that with me. It's helpful. Thank you.
Seeing no further questions, thank you very much for your testimony today. And this does conclude the bill hearing on House Bill 1002, and we're going to move to House Bill 975. This is health occupations, massage therapy, advertising. This is Delegate Gazzoni, if you want to approach the table and go ahead and bring your panel. And Mr. Foley, thank you very much for being with us today. Good afternoon, Madam Chair, Madam Vice Chair, and members of the Health Committee. I'm Delegate Pam Gazzoni, representing Howard County's District 13, and I am here in support of HB 975, which would establish new guidelines and regulations for massage therapist advertising. HB 975 requires licensed massage therapists to include their full name and license number in all advertisements. It also addresses a gap in the current statute, which does not explicitly prohibit advertisements that offer or imply prostitution services, escort services, or other sexual services as part of massage therapy. This bill fixes that and is an important step towards protecting consumers. By requiring clear identification and prohibiting advertisements that suggest sexual services, the bill helps consumers have confidence that the services being offered are legitimate and provided by properly licensed professionals. At the same time, this bill also protects licensed massage therapists. Without clear advertising standards, bad actors can misrepresent themselves, operate anonymously, or advertise illegal services. This undermines public trust in the profession as a whole. Ethical practitioners should not have to compete with individuals who blur the line between therapeutic services and illegal activity. By prohibiting advertisements that state or imply prostitution, escort services, or sexual activity, including ads on websites known for such services, this bill draws a firm and appropriate boundary. It reinforces that massage therapy is a healthcare service, not a cover for unlawful activity. HB 975 also strengthens efforts to combat sexual exploitation and human trafficking. Historically, massage parlors have been a front for and have exploited vulnerable individuals. By restricting these advertisements and giving the State Board of Massage Therapy examiners enforcement authority, the bill helps to prevent
massage businesses from being used as means of sexual exploitation. Just want to note that there are a couple amendments from the massage board. One is essentially clarifying language, and the other has to do with the language around enforcement authority. Both are fine, and I will share them with the committee if they have not already been shared. In sum, this bill aims to protect consumers, ensure public trust in massage therapy services, and strengthen efforts to fight sexual exploitation. Thank you for your time, and I respectfully request a favorable report on HB 975. And I will turn it over to my panel.
Thank you so much. Good afternoon, Chair Bagnall, Vice Chair Collison, and committee members. My name is Lisa Smith, and I represent American Massage Therapy Association, Maryland chapter. And I did want to mention that the Maryland Board of Massage Therapy examiners testified on the cross-file in the Senate, but my understanding is they could not be with us here today in person, so I did want to just take a quick minute to let the committee know that AMTA Maryland does not object to the board's proposed amendments. That would, number one, clarify the names of massage therapists on clarify that the names of massage therapists on advertisements must reflect the name on the license. This provides more transparency for the public and is consistent with the goal of the bill to improve public safety. And number two, the amendment language will clarify that the board has the authority to set appropriate penalties when they implement the legislation and establish new regulations. So that's it, and I respectfully ask for a favorable report on House Bill 975, and thank you to Delegate Gozoni for bringing this important legislation.
Good afternoon, Chair, Vice Chair, members of the committee. My name is Chelsea Adams-Cook, and I'm a licensed massage therapist in Maryland, currently serving as the president of the American Massage Therapy Association Maryland chapter, representing professional massage therapists across the state. I'm here in strong support of HB 0975. As a licensed massage therapist, we are healthcare professionals dedicated to safe and quality care to the public. We complete extensive education, pass national examinations, undergo background checks, and adhere to strict ethical standards. Maintaining the trust of our clients and our communities is foundational to our profession. Unfortunately, the current statute does not include provisions that protect against the misuse of the word massage in advertising of prostitution or sexual services. Without clear language in the statute, customers are not protected from harmful advertisement of illicit businesses that aim to undermine the integrity of our profession. This bill establishes clear and enforceable standards for advertising by prohibiting advertisements that state or imply prostitution, escort services, sexual services, or sexual activity as part of the massage. This bill provides clarity to the public and law enforcement alike. It draws a firm but necessary line between legitimate massage professionals and illicit activity. Additionally, the requirement that all advertisement includes the full license name of the licensed massage therapist or registered massage practitioner is a critical transparency measure. This allows consumers to easily verify the practitioner's credentials through the Maryland State Board of Massage Therapy Examiners license lookup system. This is a simple safeguard to empower the public and confirm that they are seeking care from a licensed professional and guards practitioners from inappropriate advances. This bill makes it significantly more difficult for unlicensed or illegal operators to conceal their activities. The American Massage Therapy Association Maryland chapter supports strong, consistent protections that address illicit practices and that put practitioners and the public at risk and erode the professional credibility. HB 0975 is a practical, reasonable, and enforceable step to ensure public safety. For those reasons, I respectfully urge a favorable report for this bill. Thank you so much.
Good afternoon, Madam Chair, members of the committee. Thank you for your time again. My name is Nicholas Staggerwald. I'm with Turnaround, Inc. We are a comprehensive service provider and rape crisis center for the Baltimore region, as well as a human trafficking service provider for the entire state of Maryland. I'm here today with the Maryland Human Trafficking Task Force, which was formed in 2008. This is composed of law enforcement, victim services organizations, survivor leaders, government agencies, and local task force. Our CEO serves as their co-chair of their legislative committee. Together, this task force has helped to recover thousands of survivors and put prosecution of hundreds of traffickers across the state of Maryland. These establishments often advertise online through sites such as USA Sex Guide with the sole purpose of promoting prostitution while concealing operations behind what appears to be a legitimate business. Our CEO has also served as a prosecutor and advocate for survivors, and in her many years of prosecuting these cases, as well as our years of serving survivors of human trafficking, these survivors tell us that these establishments, they report to us, of being forced to perform sex acts for up to 10 to 15 men per day. Many describe being made to live in deplorable conditions and being denied food if they fail to meet their daily quotas of men served. This bill provides a practical and effective tool for authorities to address this form of trafficking and hold exploitative businesses accountable. It is a straightforward approach that strengthens enforcement while centering survivor protection. For these reasons, on behalf of the Maryland Human Trafficking Task Force, Turnaround, and the survivors that we serve, we respectfully request a favorable report. We've also submitted written testimony and are able to send actual numbers if the committee would like. Thank you.
Thank you very much for your testimony. I'm going to open it up to questions from the members. Delegate Hill.
Thank you very much, Madam Chair, and thank you, Delegate Gazzoni, for this bill, and thank you all for your work. I would like to have a better understanding of how this bill will work to get at what you want, which is to stop the illicit activity. So as I understand it, this would allow the board to monitor its own licensees and to penalize them for advertising illicit activity. But the board has no authority over the bad actors who are actually doing and advertising the activity. So in other words, if someone is not really, if it's a massage therapist who's actually performing a sex act, you got them through this bill. If it's a non-massage therapist who's just advertising that they are, but it's really a front for a sex trafficking ring, they're not under the authority of the board. This doesn't affect them. So is the goal then that because of this, the police and investigators will be better able to identify? Because if they're advertising it, it must not be legitimate, and they'll therefore be able, law enforcement will be able to go in. I mean, you understand what I'm saying? This won't affect the bad actors. So how does this help us stop the bad actors?
Well, we passed an aiding, the massage board has the aiding and abetting bill that was passed, I believe, 2 years ago. So with having the name that is consistent with the name that's on their license, one, the board will more easily be able to look that up. I can tell you, I know people personally that do not perform massage using the name on their license, but as a nickname. So having this be able to prove that, but if they don't have a name that's consistent with the board, the aiding and abetting law then comes into play.
And if I may, I'd like to bring up one of my colleagues from the Human Trafficking Task Force. She's also signed up to testify as well.
Do you want to hold your question till she comes up? I can hold it till she comes up. Okay.
Thank you. I really appreciate it. Thank you so much, Madam Chair.
I was going to say, why don't we finish this panel?
Okay, great.
And then we'll ask the question.
Sure. Wonderful. Thank you, Madam Chair.
Delegate Kipke.
Thank you, Madam Chair. Thank you for the bill. I'm just curious, there are these chains like Massage Envy and there's others. How would they comply with their advertising? Because obviously you can't put the names of all the, you know.
Yes, Delegate, that's a great question, and we've discussed this. Certainly be happy to work with the committee on this issue. As currently drafted, you are correct. Those entities would be exempt from the requirement to list all of the names in an advertisement.
So as it's written, they're already exempt?
The other requirements in the law will still apply. Mm-hmm. However, they will not have to list all of the massage therapist individual names as currently drafted.
Thank you.
All right, seeing no further questions, I just wanted to check with you, Delegate Gazzoni. There was a question about an additional amendment from the Federation of State Massage Therapy Boards about physical signs versus online advertising. Have you spoken with them? Is it something you're considering? They were just asking about alignment
Go ahead.
I don't believe we've seen that, Madam Chair, but we'll be happy to work with anyone on that. I know that we had a lot of discussions with during the drafting process about how to get that correct, so we can continue working on that, no problem.
Okay, thank you very much. Seeing no further questions, this concludes the testimony of this panel. We do have another witness, Jody Finkelstein, if you want to come and begin your testimony. This is also favorable.
It must have been something I said. I cleared the panels. Hopefully that won't happen with all of you. Good afternoon. My name is Jody Finkelstein. I am pleased to be the Executive Director of the Montgomery County Human Trafficking Prevention Committee, as well as the Executive Director of the Montgomery County Commission for Women, and also a proud member of the State Human Trafficking Prevention Task Force, which was recently described. The Montgomery County Human Trafficking Prevention Committee is a committee in Montgomery County which is tasked to reduce and prevent human trafficking in Montgomery County. We wholeheartedly support HB 975 for all of the reasons already explained. And the other one and very important point that I wanted to share is that in Montgomery County, we recently launched the Look Before You Book campaign to educate the public on the differences between legal and illegal massage and acupuncture businesses. And to your point, Delegate Hill, recent police inspections revealed numerous with a capital N establishments using sexually suggestive advertising while falsely claiming to employ licensed professionals. This campaign was no small feat. It took us about 2 years to complete, and we worked very closely with our health inspectors, the Montgomery County Health and Human Services, as well as the Montgomery County Police Department Vice Unit. And just as an aside, having worked on this issue for as long as I have been carrying this advertisement with me since the beginning of this campaign, just to keep reminding myself and to ensure that I could be here today to be able to support such an important bill. It not only, for the reasons stated, it is important, but it truly will end these deceptive practices, and it strengthens the oversight and really protects the workers and consumers and sends a clear message that massage therapy is a legitimate and regulated profession, and both, thankfully in Montgomery County and hopefully the state of Maryland, will not tolerate the misuse of the professional credentials to continue to facilitate this awful exploitation. And it's for these reasons and the end of my 2 minutes that I support this bill, and I hope that all of you do as well.
Thank you very much for your testimony. Delegate Hill.
Thank you, Madam Chair. How did you know I had a question? So let me go through. Now I think I understand there are 3 categories. So there are licensees who are legitimately carrying out massage businesses and are besmirched by the implication that they're just there for sexual play, and certain people receiving a legitimate massage may make advances on them thinking that that's okay. We've seen that.
Correct.
Okay. Then there are the illicit players who say massage, wink, wink, but they're really there to provide sexual favors.
Correct.
And their businesses allow people to go in who want sexual favors without people knowing they're going in there for sexual favors, right?
Wink, wink.
But it sounds like there's also another category that I wasn't understanding, which are licensees who, under the guise of the cover of their license, might be providing. Is that, I mean, so again, I'm trying to get how does this stop?
Sure.
Category 3 and 2. I understand, I think, that as a legitimate consumer of massage services, this would say if they're advertising sex, don't go there, but I think I know that already, right? So for consumers, I'm not sure it makes a difference, so I'm trying to understand how it helps us get at the sex trafficking.
I am not a licensed professional massage therapist, so that you guys might want to answer that, but I would say, having worked with the vice unit, as long as I have, if they go into an entity where they are licensed massage therapists and they are providing these additional services, they would certainly be arrested for prostitution.
Right, but that's as it is now.
Correct.
So that doesn't change.
Right, but yes, that is how it is now. So, but however, this bill really addresses those bad actors that are using these licenses to be able to bring in additional clientele and provide services that they're not professionally trained for.
So sort of that third category, they're fronting legitimately, they have licenses, but then they're bringing in non-licensees to do the other stuff.
Correct, and if I might add to this, it's not just licensed massage therapists, it's other individuals who provide body works who are not licensed, who are also engaged in these illicit activities. We have found when we were doing all of our body works inspections, and at least 20 different, in at least 20 different body works establishments, they had the same certificate from the same educational institution to be able to provide acupressure, which certainly isn't the case. And the state of Maryland is also considering a very similar bill that I think is before you as well, which truly go hand in hand. And in a more practical way, not only does this elevate the massage therapist as a profession, but it really protects the public to know the difference between what an illicit massage therapy establishment would like versus one that is not. And that's the whole goal of our campaign, because I really feel that as a society, law enforcement can do what they can, our wonderful our massage professionals can do what they can, but there's also a public aspect to this where the public has a responsibility to report illicit behavior and help protect their own communities, and to be able to assist those individuals who might be trafficked in these instances. I can't tell you how many bodyworks establishments we went into where the workers may not have been trafficked per se, but they were certainly exploited, and this advertising is part of that exploitation.
Thank you.
Sure. Thank you for that wonderful question.
Are there any other questions from the members for this witness? Seeing none, thank you very much for your testimony. This does conclude the hearing on House Bill 975. We're going to move to House Bill 838. Madam Vice Chair, do you want to do both of your bills back to back? So you take absolutely. Just want to make sure that you don't have to come back to grab anything. Yeah. All right, so House Bill 838 is the State Board of Pharmacy Prescriber Pharmacist Agreements. So Vice Chair Cullison, if you want to come to the table and bring your panel, and you can get started with your testimony when you're ready.
Is that everybody? Jasmine, is Ann still here? I don't see Ann, okay. So, thank you, Madam Chair. This is the easier one of the two that I'm going to do. So let's, I think that we can just say, let's move favorable on this. Before I get started, good afternoon, still afternoon, Madam Chair, committee members. I want to thank my intern, Marwa Mamani, who did the research on this and did a terrific job, and I just want to give her a shout out. I know she's not feeling well today, but I bet she's watching. So I'm here today, I'm Bonnie Cullison, representing District 19, and I'm here today to speak on behalf of HB 838, State Board of Pharmacy Prescriber Pharmacist Agreements, opioid use disorder treatment. The bill seeks to address the opioid crisis by creating a physician-pharmacist agreements, okay? A physician-pharmacist agreements that allow pharmacists to treat opioid disorder under appropriate supervision. It has emerged as the result of a clear need. Maryland has experienced devastating losses from opioid-related overdoses. More than 2,500 Marylanders died from drug overdoses in 2023 alone, with opioids involved in nearly 80% of those deaths. With all the improvements of treatment for harm reduction in the past, access to medication for opioid use disorder remains a critical area for improvement. A Maryland Health System analysis notes that as of 2019, 8 Maryland counties, 1/3 of all counties, had 5 or fewer clinicians authorized to prescribe buprenorphine for opioid use disorder, indicating additional geographic disparities in access to care. Delays are dangerous and in some cases fatal. Research shows that timely initiation of the medication for opioid use disorder significantly reduces mortality and relapse risk. And when access is postponed, the risk of overdose increases. This bill addresses these gaps by allowing qualified pharmacists working under collaborative agreements with prescribers to serve as an additional accessible point of care. It makes 2 targeted improvements. First, it removes duplicative administrative requirements that currently require prescribers to submit agreements to multiple regulatory boards. And I will tell you, it was the boards themselves who asked for that, to remove those duplicative documents. Secondly, it clarifies that pharmacists who meet training, registration, and licensure requirements may enter into agreements to treat opioid use disorder using controlled dangerous substances with mandatory prescription drug monitoring program checks before or initiating therapy. I want to be clear, I'm not asking for independent prescribing authority on this bill. Other states have demonstrated that this model works. Washington, Colorado, California, and Oregon have all implemented legislation that has expanded this kind of agreement. The models have expanded access and maintained strong patient safety outcomes. I recognize that some stakeholders have expressed concerns in prior legislation about expanding the authority of pharmacists in this area, particularly around controlled substances, but this bill does not seek to replace physicians. It reinforces the collaborative care through the involvement of qualified and trained professionals, pharmacists and physicians with the capacity to save lives. It doesn't weaken oversight, it streamlines it, and it reflects one simple truth: treatment only works when people can access it. In order to qualify to enter into these agreements, the pharmacist must register with the Drug Enforcement Administration and the Maryland Office of Controlled Substances Administration, complete required training, and conduct the PDMP program reviews before initiating or modifying any controlled substance therapy. These protections are central to the bill and underscore the dedication to evidence-based intervention and intentional intervention. For both public health and equity perspectives, expanding rate, regulated access points are essential. Communities experiencing the highest overdose rates are often the same communities with the fewest providers and the greatest barriers to care. This bill reflects thoughtful collaboration with pharmacists, prescribers, regulators, and advocates. It builds on proven models. It strengthens accountability, and more importantly, it helps ensure that when someone is ready for recovery, our system is ready for them. For those reasons, I respectfully request a favorable report on House Bill 838. And I'll turn it over to my panel.
Good afternoon, Madam Chair. Thank you, Madam Vice Chair. And good afternoon to the other members of the Health Committee. My name is Dr. Jasmine Ebron, and I am a board-certified, resident and fellowship-trained pain management clinical pharmacist who has a subspecialty in addiction medicine. Today, I'm testifying in support of HB 838. Improving access to treatment for opioid use disorder is a national public health priority. At least 10 other states permit pharmacists to prescribe controlled substances, including buprenorphine, under collaborative practice agreements. Pharmacists are uniquely positioned to support buprenorphine management through monitoring for efficacy, safety, adherence, and diversion, while providing comprehensive medication education. The literature consistently demonstrates that pharmacists' involvement improves patient outcomes, reduces healthcare costs, and decreases physician burnout. Pharmacy schools and residency programs have prepared pharmacists to deliver high-level patient care in both the inpatient and the ambulatory care settings, equipping them to meet the complex demands of opioid use disorder management. Initiation of buprenorphine therapy can require 2 to 3 hours for the initial visit, often followed by multiple appointments within the next couple of weeks to safely titrate up the dose. The maintenance phase may be achieved within days to weeks, but patients require close monitoring for relapse and diversion. Maintenance treatment commonly continues for months to years, and when discontinuation is appropriate, careful tapering is necessary and may extend over several months. By supporting this bill to permit prescriber-physician collaboration agreements, you are reducing the barriers for patients who cannot afford to wait weeks for a physician appointment. And you are helping to ease the physician burnout while ensuring that patients receive close monitoring, education, and follow-up that medications like buprenorphine therapy demands. Thank you.
Good afternoon. My name is Aaliyah Horton. I am the Executive Director of the Maryland Pharmacists Association. I'm also representing the Maryland Pharmacy Coalition today. Both of the panelists did a very thorough job in outlining this bill, so I won't take up too much time in that I submitted written testimony, as well as MPC had our legislative day last week, and there was also documentation that was shared with your offices. But I wanted to mention that this is really an opportunity to highlight that pharmacists and pharmacy is not a monolith, that our pharmacists have expertise and practice in various areas that can really expand and extend access to care in communities that really need it. And so this is a really great opportunity to do that. And I think which was also mentioned in terms of ensuring adherence to these treatment plans, identifying when relapses are happening early, and really strengthening transitions of care from emergency departments and outpatient clinics. And I also want to mention, it's my understanding that MedChi has submitted a letter of support on this bill. And so hopefully that reduces quite a bit of the conversation that we typically have. So thank you, and I urge a favorable report on House Bill 838.
Thank you very much for your testimony. I have Ann Seacott on your sponsor panel.
There she is. She's next door real quick. My apologies.
No, you were fine. That's why I was asking. So you can go ahead and start your testimony.
Thank you, Madam Chair, members of the committee. I'm Ann Seacott, testifying today on behalf of the National Council on Alcoholism and Drug Dependence. You also have testimony in support of this bill from the Maryland, D.C. Society of Addiction Medicine. Access to buprenorphine is a problem, and this is one of probably a number of things that could be done to try to increase access. Delegate Gazzoni, not to put you on the spot, but Delegate Gazzoni was on a work group that you all created through legislation last year to look at some of those access issues, and this is one of them. The issues around transportation, issues around there being enough prescribers who are willing to prescribe buprenorphine and work with people with opioid use disorders. So this is one way that we can increase access in a very meaningful way by trained health clinicians who are able and willing to get involved in helping people with this very effective and, by the way, very safe medication. So we ask for your support for the bill.
Thank you for your testimony. And I will point out to the members that there is a letter of support stating that this is an early recommendation from that ongoing work group. Let me open it up to the members. I saw Delegate Warman, followed by Tavares, followed by Gazzoni.
Thank you, Madam Chair, and thank you, Delegate, for bringing this bill. So I know that buprenorphine and other medications, can be used for opioid use disorder, but are also being prescribed for pain management. Would a patient seeking, being prescribed this for pain management be able to get this drug through the pharmacist under this, or just for opioid use disorder? Thank you.
So I do want to clarify. So the FDA-approved indication for buprenorphine for pain management is actually a different formulation and a different dose of the medication that you more commonly are thinking about, perhaps, which is the Suboxone. So these are two different medications, two different doses. The way that it's written right now, my understanding, it specifically calls out opioid use disorder. But in terms of determining who would be appropriate for this medication in the first place, I think that, that assessment would need to be done. And that's why this is, a physician and pharmacist collaboration. So the physician would still be very much a part of perhaps the diagnosis, because that would be their scope, right? So, but as a clinical pharmacist, I don't have, diagnosing abilities. That would be outside of my scope of practice. But once the diagnosis was made, then as a clinical pharmacist under this law, then I would have the ability to initiate and monitor and do some dose adjustments. But from a pain management standpoint, if buprenorphine is given, oftentimes you'll see it given in a different dose.
Got it. Thank you.
Thank you. Delegate Tabatis.
Thank you, Madam Chair. Thank you for that distinction. I'm going to build on that. The issue that I see with this particular product is what I see, at least in my community, which is that those individuals that have been given Suboxone have become addicted to Suboxone. So how, if this is supposed to get them off of fentanyl or heroin or Tranq or whatever, how is that doing it by supplanting one drug with another?
Yeah, thank you for that question. So if I can, I would like to just clarify and kind of distinguish the difference between being opioid dependent to a medication versus developing an addiction. When we classify a patient who's developed an addiction to a medication or a chemical, that is really defined very specifically by DSM-5 criteria. So oftentimes what we'll say is that the patient has become dependent and tolerant to this chemical buprenorphine. And it is an important distinction in terms of how the patient behaves after being placed on this medication. But when you think about treating a chronic illness like opioid use disorder, I would encourage you to think about it like, for example, maybe diabetes. So a patient who has diabetes, we are going to use a treatment that is going to be a chronic medication. And sure, there is stigma with this medication, and we are very aggressively working towards addressing that stigma, but buprenorphine, which is used obviously for opioid use disorder, or Suboxone, is a chronic treatment. So if the patient develops tolerance or opioid dependence to the medication, then it's very different from developing an addiction, I would say, to the chemical itself. So it's important just to kind of separate those two out. But the same way that in pain management clinics or in addiction medicine clinics, we would have to taper a patient off of the medication because their brain has developed dependency or has become tolerant. We would do the same thing for buprenorphine medication. It's not uncommon for a patient to be given Suboxone for maybe 1 year or so, 2 years or so, and then reach a place where they are now stable. So they've developed opioid dependence, and they've been stabilized, to their opioid dependence, and then a year or two later be at a place where they could be tapered off of the chemical. And we would do that if that was necessary. But in any case, a slow taper would be typically recommended as the treatment plan, which is different from, a patient being addicted to a medication used to treat the illness.
Can I just have a follow-up? Given the irregularities in the healthcare market, in the behavioral healthcare market with this population, I'll just be honest, I'm not seeing that continuity of care with this population that resides in an open drug market.
So Delegate, I think that's what this bill is trying to address by providing the consistency of the going to your local pharmacist as opposed to having to go back to your physician frequently. I think you will see greater continuity of care and access here, and that's what they're experiencing in other states that have done this model.
I would love to see some of that research, so I could be set at ease.
Okay.
I'd appreciate that, thank you.
We can get that for you, thank you.
Delegate Gazzoni.
Thank you, Madam Chair. I feel like I'm just going to ask a Me Too kind of question. Or isn't it true? But having been on a good number of the work group meetings, first of all, the first pharmacist discussion that we had, I was like, wow, this is really an area where we could make it easier for pharmacists to be involved in the process, and I think that this bill does that. And isn't it true that many times people struggling with SUD, when they have an overdose or have had a hospitalization visit, that's the best time to catch them? Because they'll be more interested in trying to get help and get out of the trouble of it all. And that this helps with that, because there's less of a gap between when they have an overdose, as an example, and they leave the hospital, because oftentimes that's quite quickly. This is a process that can get them into treatment faster and get them access to buprenorphine in a more faster way that helps all the way around, because it also, buprenorphine takes away that need to get
The next chemical.
the next hit, yeah.
Yeah, no, I would agree with that completely. So if we are able to initiate this medication in the urgent care setting, that would be ideal. And what we're talking about is not delaying access. And so also, what is just as important is if we are able to initiate this medication earlier, then coordinating the follow-up once patients leave their urgent care, and then whatever program perhaps they might follow up with, that also would be easier as well.
Can a quick follow-up, please? Thanks. No, I just sort of, and also I do want to kind of reiterate again, isn't this true? That this, particularly in rural areas where treatment is just harder to find, particularly treatment that is not challenging to get to, this is another thing that can be really helpful if their local pharmacist, who they probably know, is able to kind of help ensure that things are moving along.
Right, yes. So, pharmacies are located and easier to get to, as you just stated. So, in rural areas where patients are having a harder time finding an addiction medicine physician or provider or even a nurse practitioner, this would bridge the gap. Sometimes it's difficult to get an appointment, a follow-up appointment with your physician. And typically, pharmacists who are trained in this particular work would be more accessible, titrating up or titrating down, tapering off. That would be easier with a pharmacist who you already have a relationship with, and that you can partner with to get to what we consider to be a maintenance dose for those patients, for sure.
Thank you so much.
Seeing no further questions, I just wanted to ask the sponsor, there's a letter from the American College of Nurse Midwives with a potential amendment. Have you seen that?
Yes, I have, and I consider that a friendly amendment.
All right, excellent. Thank you very much for your testimony. I lost my page. This actually concludes the bill hearing on House Bill 838. So we're now going to pivot seamlessly to House Bill 944, which is the Maryland Health Care Commission Certificates of Need and Material Changes Transactions. Vice Chair Cullison, if you want to call your panel, and you can get started with your testimony whenever you are ready.
So, Catherine here. Catherine? Yeah. Catherine and Sarah? Okay. Doug? Thank you again, Madam Chair and members of the committee. Bonnie Cullison, representing District 19, here today, here now, to present House Bill 944 to you. Healthcare consolidation, especially private equity-driven deals, has repeatedly resulted in higher costs, reduced staffing, deteriorating quality, and less local control. This is evidence-based, documented in the literature. Outcomes that can harm patients, workers, and communities. We've seen this in nursing homes where financial engineering and layered debt left vulnerable people with fewer staff and worse care. We cannot let that pattern spread across our primary care, outpatient surgery, health care, and specialty practices. House Bill 944 creates a targeted time limit public interest review for large case transactions. So those are mergers, acquisitions, joint ventures, contracts transferring control that involve at least $10 million in assets and revenue. Its goal is not, to block investment, but to protect patients, workers, and communities from the harms of unchecked consolidation, especially when private equity deals that raise costs or worsen care. So here's a couple of things that are important to think about. Independent physician groups and outpatient providers are declining across Maryland. Ownership by corporate and private equity buyers is rising. So, and for example, there's a very high incidence of private equity ownership among dermatologists and ophthalmologists in some counties. So what does that mean for us? It means potentially that when you go to your dermatologist to get a spot checked, you're more likely to be authorized or advised to get a procedure that costs more, that you might not need. And the visit may get shorter and there may be more return follow-ups to charge more copays. We might have to wait longer for less attentive care. The reason is these private equity firms their mission is profit. They are serving their stakeholders. That is their primary responsibility. They do that in their maintenance and control over a very important healthcare setting. Evidence shows that consolidation can increase unnecessary high-profit procedures, reduce staff, and degrade quality. We've seen this here in Maryland, and the Maryland Health Care Commission dealt with this with nursing homes, where we saw a clear pattern of financial engineering, staffing declines, worse outcomes, and legal exposure. Other states, and there's a number of them, at least 8 of them, have enacted similar public interest review models. MHCC has enacted such a model with nursing home transaction and has the expertise to expand this review without creating a new agency. MHCC already oversees similar nursing home reviews and has the expertise to apply the same protections elsewhere without it will protect Maryland families from surprise price hikes and shrinking access. So how do we do this? What's the process? It's a fairly simple process. And again, it's only going to happen in these transactions that are worth more than $10 million in assets. There's a public notice 90 days before qualifying transactions. So they have to notify MHCC that the transaction is going to be happening. MHCC screens the application for using clear criteria. If the MHCC suspects a substantial risk, a focused public interest review is done, and that can take up to 60 days to approve conditioned, or denied the deal based on affordability, quality, access, staffing, and equity. MHCC, as I said, already does this for nursing homes. We're asking now that we give them the authority to do this with some of these other transactions. So for the health and financial security of our communities, I respectfully request a favorable report, and I'll turn you over to the Executive Director of MHCC, Doug Jacobs.
Thank you so much. Good afternoon, Chair. Thank you, Vice Chair, members of the committee. My name is Doug Jacobs, and I'm the Executive Director of MHCC, and we're in strong support of House Bill 944. Right now, as was just described, we're seeing a rapid shift in who owns and operates healthcare facilities in Maryland. MHCC has studied these trends for years. Physician practices, home health agencies, hospice providers, ambulatory surgery centers, other non-hospital facilities are increasingly being acquired by private equity. Some of these transactions may represent important access to capital, but research has shown that oftentimes these transactions more often lead to reductions in staffing models, reductions in service lines, or limitations in actually taking Medicaid patients, all of which can affect patient access, affordability, and quality of care. And today, Maryland has no consistent oversight process here outside of nursing homes. House Bill 944 fills that gap. It would create a streamlined process for public notice. So after that public notice, MHCC would have 30 days to determine if we were to undertake a public interest review. Most would not undergo that public interest review. It's only for those potentially problematic transactions, those involving significant impacts to healthcare quality, access, affordability, that MHCC could conduct this 60-day review and approve with conditions, or deny the transaction. But this is not about blocking investment. It's about making sure that significant ownership changes support rather than undermine Marylanders' access to high quality and affordable healthcare. The General Assembly recognized the importance of this approach last year when it established similar public interest review framework for nursing homes. And House Bill 944 extends that same common sense oversight to the rest of the care continuum. Before rising acquisitions reshape care delivery in ways that are difficult to reverse. House Bill 944 provides the right solution for Maryland, and we've engaged with stakeholders throughout this process and remain committed to working with them going forward. For all the reasons discussed today, the Maryland Healthcare Commission respectfully requests a favorable report. Thank you.
Sarah, you want to go ahead?
Good afternoon, Chair, members of the committee, and thank you to the Vice Chair for her leadership in sponsoring House Bill 944. My name is Sarah Westrick, Advocacy Director for AARP Maryland, representing our 850,000 members across the state. We're also a member of the Maryland Senior Citizen Action Network, which is also favorable on this bill. Maryland is seeing a rapid growth in the acquisitions of healthcare entities across many sectors. These changes are raising real concerns about affordability, access, and patient safety. We've witnessed the consequences in nursing homes where private equity ownership has too often led to declining care quality. Similar practices are now emerging in other areas of the health system, including physician practices, and that's why AARP Maryland strongly supports this bill. Consolidation and private equity acquisitions have consistently been linked to higher cost, reduced staffing, and lower quality of care. This bill requires public notice of major transactions. This gives patients and communities time to understand how these changes might affect their care. It also directs the Maryland Healthcare Commission to evaluate whether a transaction would increase market power or reduce competition. Importantly, the bill ensures that these reviews consider cost, quality, continuity of care, staffing, and access, aligning with our state's broader healthcare goals. The Commission can bring in outside experts without using state funds, and the bill provides flexibility for expedited review when appropriate. Too many Marylanders have already felt the negative effects of healthcare consolidation. This bill gives the state the tools to protect patients and maintain high-quality, accessible care. For these reasons, AARP Maryland respectfully urges a favorable report. Thank you.
Good afternoon, Madam Chair, members of the Health Committee. For the record, my name is Catherine Kirk-Robbins. I'm Deputy Director at the Maryland Citizens Health Initiative. I want to thank the committee for the opportunity to testify in support of House Bill 944. I additionally have a long list of things I'd like to thank Vice Chair Collison for, and sponsorship of this bill is among them. We are here today largely because we believe that the increased oversight that this bill would provide to MHCC is an important protection for consumers. As you heard from other panelists, we know that private equity in the healthcare sector can lead to increased cost and diminish quality. And so we also know that private equity is increasing. So as early as 2021, 50% of physicians in Prince George's County and 60% of all urologists in the state were associated with private equity. And this poses a real threat to the healthcare delivery to the patients in our state. So we believe that this bill will increase transparency and in turn can reduce cost and sort of safeguard those staffing guidelines. So we respectfully urge a favorable report on House Bill 944.
Thank you for your testimony. Are there questions from our members? Delegate DeVette.
Yes, thank you, Madam Chair. So I just want to make sure I heard you correctly. I was talking about the fact that over 50% of the physicians' practices in Prince George's County are owned or affiliated with private equity organizations. So can you just say a little bit more about what that might mean for the care delivered in the county?
So I can take it. Thank you so much. That's absolutely right. We did a report in 2025 that showed actually in 2021 data, there was already more than 50% of physicians in Prince George's County owned or affiliated with private equity. That's a challenge because national research, including here in Maryland, shows that when physician group practices are owned by private equity, there's increased turnover in physicians. There's decreased autonomy for those physicians. They're more likely to be replaced by advanced practice practitioners. And they might be excellent advanced practice practitioners, but at the same time, you're losing that continuity of care. If you've relied on your community physician for so long, and now that practice gets acquired by private equity and you can no longer go to them, you no longer have someone there that knows you, and that's a real challenge.
Where everybody knows your name, right?
Exactly, yeah.
Cheers, right? Okay.
Delegate Hill, followed by Delegate Alston.
All right, thank you, Madam Chair, and thank you, Madam Vice Chair, for the bill. So there's some opposition here, and they raise a couple of issues. It's either overly broad, or it is burdensome. This is a problem. So I don't think those are complaints that are new to you. So how have you tried to address the process? How are we getting greater transparency? What would you say?
Yeah, thank you so much for the question. And we've been really, we're really thankful to be working with both all the folks in support of this bill, the folks in opposition, and we've been talking about a lot of these issues, and we'll continue to do so. But we've intentionally designed this bill to really address some of these concerns. The process that we've outlined, a public notice for all these transactions above $10 million, and then only a select few transactions then that get reviewed 30 days later, for the whole process taking less than 90 days, is a very streamlined process. And it gives that added transparency to the majority of these transactions, but really only a focus on those that are the most potentially problematic. As folks have talked about, the decline in quality that we've seen in skilled nursing facilities, we know that there's a statistically significantly worse quality in those that have been acquired in the last few years. After we got oversight over this process, it is very difficult now to change the quality in those skilled nursing facilities that have already been acquired by private equity or other groups. I can talk a little bit more if desired about some of the ways that restructuring occurs. And so what we don't want to have happen is to have so many of these transactions across the rest of the healthcare continuum that that many of these other facilities are irrevocably broken and in terms of quality. And so we think that now, as these transactions are rising in these other areas, it's important to have first visibility and second oversight only when warranted.
Okay, thank you very much.
Delegate Alston, followed by Delegate Kaufman.
Thank you. And for whoever is best, as we often talk about in this state, our emergency wait times are a big problem. Can you talk about how the acquisition of post-acute care settings, particularly by private equity firms, are affecting the ED wait times?
Yeah, sure. I can go. There is a connection here. When private equity groups acquire skilled nursing facilities, home health agencies, hospices, what we see is that those entities, those important post-acute care providers, they are much more choosy in what kind of patients they accept. So no longer accepting patients with complex care needs, no longer accepting oftentimes patients on Medicaid. That means that when hospitals are discharging patients, they can't find a place for them to go anymore. And that causes a backup in the hospital where patients can get discharged. The patients in the emergency department can't find an inpatient bed, and leads to worsening ED wait times. So we really see a connection here, and we recognize that this is a problem in the state. So, so this could be part of a focus in solving those issues going forward.
Thank you. Thank you.
Delegate Kaufman.
Yes, I'm not going to quote from their letter, but I'm just curious if anybody's had a chance to engage with the Maryland Hospital Association over their opposition, or if anyone would care to respond to some of their assertions that they make.
What I can say, Delegate, is that we are committed to continue to work with them to see if there's a path forward for us on this, because I think they are equally concerned about making sure that patients are getting high quality care. I mean, that's what our hospitals strive for. So I think, I think we probably agree on a lot of the content or the concept here, but we've got to work together to figure out how to make it, what the language and the policy needs to be.
Thank you, Madam Chair.
Seeing no further questions, I just had a couple. Following on what Delegate Kaufman said, I did notice a concern that you had not engaged with stakeholders, but I believe that you spoke to a pretty exhaustive process engaged with stakeholders. So could you just share with us what that process has looked like?
Yeah, thank you so much. So I'll share a few points here. MHCC has been studying this issue for years, and in the creation of these studies, we've been very purposeful about engaging stakeholders. And so we just came out with a report in 2026 that identified the effects of consolidation, both on the insurer side and the provider side, also inclusive of private equity. And before we published this report, though, we had a provider-focused listening session to hear feedback on the report, a plan-focused listening session to receive feedback on the report. One of the outcomes of that report was a recommendation to do what we're here to talk about today. Also, we distributed a draft legislation about a month before session started, have been engaging with stakeholders. I've reached out and talked to, I think, everyone who's going to testify today, both support with amendments and oppose, and we continue to work with them going forward.
Thank you very much. And just one follow-up, because as you may or may not know, I'm in a district and county that ended up in the papers a couple of years ago when some of our cancer patients were not given information about their oncologist when the oncology suite was let go. And I'm just wondering, would this help to address that continuity of care? Because there was a great concern for those folks that they didn't have access to their docs and didn't have information until they read it in the paper, that their docs were no longer part of that facility. So
there is a connection here. what we see is that when there's a private equity acquisition, another type of acquisition, oftentimes that can mean churn of the physicians who work there, including in oncology practices. Oncology practices were one of the practices that we studied as part of our study in 2025. We've seen rising acquisitions from private equity. And what we see is that well, as part of this bill, there is public notice. And so the public can actually see when those acquisitions are happening. And so that is really important for someone that relies on those community providers. And if the transaction were to go to a public interest review process, we could receive comments from the public too. So that lets them be part of the process in ways that they probably haven't before.
Thank you very much. Seeing no further questions, this concludes the testimony of this panel. I do have Dan Shattuck as information. Do you want to come up and go ahead and give us your testimony? And then I'll move to a favorable with amendments, and an unfavorable.
Madam Chair, members of the committee, my name is Dan Shattuck. I'm here today on behalf of really all the healthcare providers we represent. We have a pretty broad array of providers, physicians, non-physicians, small practices, large practices, membership associations. And I just wanted to take a second, because we heard from the first panel the goals of the bill, and I'll just say I've been in touch with Dr. Jacobs to continue having discussions about the importance, changes that might be necessary for this bill. And you'll hear some concerns by the opposition, but I just want to remind everybody, when practices are providing care today, it's a very challenging landscape. You've heard it before on a number of bills. I think one of the prime concerns is reimbursement, their ability to get paid for the care they provide at a fair rate. And I think that continues to be an ongoing challenge as we look at workforce and being able to recruit and retain. In addition to them providing care, they're also running a business. And a lot of the costs that we see in the healthcare space, it's due to, one, things that aren't covered by insurance. So when you're running a business and you're providing the care, but then you're billing, then you're trying to follow up with denials, and you're having to go through those processes with the administrative barriers. We've brought evidence in previous years when we've talked about step therapy and prior authorization. Some of our small practices are investing in staff solely dedicated to overcoming these barriers to get, I'll say it, the money in the door from the care that's been provided. When that becomes a challenge, the groups need to look at how can we bring in somebody to help with this so we can provide the care, but we have somebody else who's handling the business side. So there's a lot of motivations in this space. I know that the Healthcare Commission has been doing great work with respect to nursing facilities. I'll say that the provider and practice landscape is a lot different. We're not talking about a defined number of facilities. We're talking about, everything, from small groups to large groups. Again, trying to find a way to survive, to continue to provide the care, and sometimes that is going to private equity. Sometimes that's merging with a larger group. So we have to take into the account the why. So that's what I want to say.
Thank you very much for your testimony. Are there any questions for this witness? Seeing none, thank you very much for your testimony. I do have Jamie DeMarco, favorable. So come on up and give us your testimony.
Thank you very much, Madam Chair, Madam Vice Chair, members of the Health Committee. Thank you for the opportunity to testify. My name is Jamie DeMarco, and on behalf of the Maryland Nurses Association, I urge a favorable report. We can attest to specific horror stories where private equity has purchased health facilities and effectively sold them for parts. There are stories of, private equity selling the land underneath the health facility, so that when the health facility used to own the land, they now have to pay rent on it. That creates a giant influx of cash for the private equity owners, but it leaves the institution chronically in debt and paying rent when they used to own. When this happens, as was testified earlier, there's analyses showing that there is consistent cuts of staff. That means our members, the Maryland nurses, lose their livelihoods, and the ones who do get to keep their jobs have the same amount of work and are working greater hours, have higher nurse-to-patient ratios, have more stress, and higher burnout. We think that this is a really important piece of legislation that is going to put some careful analysis and review from the MHCC before private equity can be purchasing health facilities, and we believe that that is going to protect our members in the state, the quality of care in the state, and positive outcomes. Thank you, and we urge a favorable report.
Thank you for your testimony. Are there any questions for this witness? Seeing none, thank you very much for your testimony. We're now going to move to a favorable with amendments. I've got Matthew Celentano, Allison Taylor, Robin Elliott, and Tina Quigley. You want to come to the table and go ahead and begin your testimony.
Good afternoon, Madam Chair, members of the committee. My name is Allison Taylor. I'm here on behalf of Kaiser Permanente, and today really speaking on behalf of their nonprofit health system rather than as a payer. The concerns around private equity are well documented, and so I certainly would encourage some of you to look into that. However, this bill does apply to all transactions over a certain size, not just in private equity. And so, we have put in some amendments, I think, to look at the scope of this. Kaiser Permanente did recently enter into a joint venture with a hospital system in Nevada to expand our footprint there and access to care. And so, we are looking at all sorts of opportunities to expand our footprint, especially into areas where we don't currently operate, sort of in the state of Maryland, like on the shore, southern Maryland. And so we just want to make sure we would hopefully be considered a good actor in that space. So we are happy to work with MHCC on some amendments, and so urge a favorable report with amendments, and happy to continue the conversation. Thank you.
Madam Chair, members of the Health Committee, my name is Matt Celentano, here today on behalf of the League of Life and Health Insurers of Maryland in support of House Bill 944 with amendments. First and foremost, we want to thank Dr. Jacobs and the MHCC team for the collaboration. We have had multiple calls, multiple discussions on multiple sets of amendments, and the conversations continue. We're committed to continuing to keep talking. We're concerned about the impact of private equity in healthcare as well, and the cost and quality measures that are impacted. In the past decade, we've seen an explosion of private equity and ownership. And after acquisition, it's common to see dramatic increases in provider group patient volume with higher prices, staff cuts, and prioritization of higher margin procedures. We get away from value. This cost cutting impacts patient experience, and is certainly focused on the shorter term to sharpen balance sheets at the expense of quality. We applaud the focus of House Bill 944, but we want to continue the discussion to make sure that existing long-term carrier relationships aren't captured by the intent of this legislation. So, as written, I should say. We respectfully ask for more time to keep working through these issues and ask for a favorable report with amendments on HB 944. Thank you.
Thank you, Madam Chair, Madam Vice Chair, and committee members. I'm Tina Quigley. I'm here today on behalf of Care First Blue Cross Blue Shield, testifying in favor with amendment on House Bill 944. I'd also like to thank Dr. Jacobs, who's been in conversation with us about the bill. And our concerns with the bill are really about process. As this committee knows, Care First Blue Cross Blue Shield is the state's only statutory not-for-profit health service plan, and our business transactions are already subject to review by the Maryland Insurance Administration. We approached the Maryland Healthcare Commission about wanting to make sure that we weren't creating a duplicative regulatory scheme when our business transactions are concerned. Dr. Jacobs acknowledged that the MIA is our primary statutory responsibility, or has the primary statutory responsibility to regulate our business transactions. And we're discussing ways to make sense of taking the additional look that this bill contemplates with respect to business transactions and to perhaps incorporate that into the statutes regarding the MIA. We suggest keeping the MIA as our primary regulator, who would then work in partnership with the MHCC on any type of review that they can bring their expertise to, and with the overall work with the MIA. We look forward to continuing the conversation to ensure that we are able to move nimbly when a business transaction is on the table, but to also provide the full review that this committee deems as necessary.
Thank you for your testimony. And I'm just going to check to see if Robin Elliott is here. She might be in another committee. All right. Let me go ahead and open it up to questions from Delegate Hutchinson.
Thank you, Madam Chair. Questions for Tina. Just curious how many physician practices you own. And does the MIA require public notice when this is happening?
The MIA, the statutes regarding our business transactions do not.
I'm sorry, because of the bell, I just couldn't hear your answer.
The statutes, I believe, do not require a public notice when we acquire practices. And we do own a couple. I don't know how many physicians are part of that. I believe it's around 100 physicians currently are members of those practices that we own currently.
Okay, thank you very much.
You're welcome.
Seeing no further questions, this concludes the testimony of this panel. Thank you very much for your testimony.
Thank you.
We do have an unfavorable panel. Steve Wise, Mark Edney, and Andrew Nicholas. Go ahead. Oh. And Joe Bryce.
Good afternoon, Madam Chair, members of the committee. Steve Wise here on behalf of MedChi. I also would like to thank Dr. Jacobs and Ms. DeShields for the time they've spent with us sort of walking through this bill. I want to make clear we're opposed to the bill, but we are not opposed to the concept. But we just think this needs some further discussion and consideration. And to give you a couple of examples of things that we think need to be thought through a little bit, it's unclear to us that this bill squarely brings health insurers into the fold, and we think that it should. And here's why. United Healthcare, for example, according to an article I read, has about 90,000 physicians in the country in its, quote, arsenal under the article, and that's about 10% of the physicians in the country. So the insurers are acquiring physician practices at quite a clip. And if we're really going to look at what's happening here with the acquisition of practices, we've got to bring insurance companies into that fold. It's not just private equity. I'll mention with regard to private equity that part of the reason it has taken such hold is it's not so much, it is a cause of some of the things you heard about, but it's also a symptom. Practices are looking for help financially because their reimbursement rates are so low, and private equity is an option. Another thing that we think you need to consider about the bill is when the commissioner or when the executive director of the commission looks at a proposed acquisition, all the factors that they're looking at are things that would come if the merger or acquisition took place. We think they should also be looking at what might be causing the acquisition to be sought in the first place. So that if we have a practice that's in peril, and maybe we don't want them to go in with a big practice and concentrate all the radiologists in one place, but if the other option is that that practice doesn't survive, we need to take that into consideration as well. Thank you, Madam Chair.
Chair Bagnall, Vice Chair Cullison, members of the committee. My name is Dr. Mark Edney. I'm a urologist in Salisbury. I'm past president of the American Association of Clinical Urologists, past chair of the American Urologic Association State Advocacy Committee, and I'm here today as a physician leader with the Maryland Patient Care and Access Coalition to respectfully ask that this committee vote no on House Bill 944. My practice, Chesapeake Urology Associates, was one of the founding members of MPCAC about 20 years ago. The independent medical practices that are members of MPCAC care for hundreds of thousands of patients each year in our community-based practices. We share the committee's concern about consolidation, and ideally there would have been a broad stakeholder work group assembled to develop legislative proposals arising out of the study performed by the Maryland Healthcare Commission. Unfortunately, we must now oppose HB 944 because it fails to respond to the realities of the Maryland healthcare market that medical practices, hospitals, and others now compete in. According to the Hilltop Institute's report to MHCC, we have not had an independent hospital in this state since 2020. Just 2 insurers, Care First and Kaiser, control more than 82% of the insurance market. In Maryland, physicians receive some of the lowest reimbursement rates in the country, approximately 85 cents on the dollar compared to the national average. This bill's low revenue thresholds, lengthy review periods, and broad approval authority would create costs and risks that only the state's largest entities, hospital systems and major insurers, could realistically absorb. Practically, this will further entrench their dominance in the market and deter smaller competitors from taking such significant financial risks. Most troubling, the bill would give the MHCC executive director complete control over Maryland's healthcare market, with the power to deny transactions after parties have already invested significant time and expense without any guardrails. In closing, we ask the committee to vote no on House Bill 944 and instead work with MHCC and stakeholders, including independent practices, to develop legislation that promotes competition and safeguards access to high-quality, cost-efficient care. And we hope that NPCAC can be a resource as you consider other legislative options. Thank you very much for your consideration.
Thank you very much, Madam Chair, Madam Vice Chair, members of the committee. For the record, my name is Andrew Nicholas, here representing the Maryland Hospital Association in very respectful opposition to House Bill 944. As has been said by other members, we absolutely share the concerns that you heard from the proponent panel around increased investment from private equity in the healthcare landscape. Our concerns are really with the bill as drafted. Specifically, the language is very broad. And so while I appreciate that it does exempt acute care hospitals, many of our hospitals, as you know, are part of larger healthcare systems, which are not exempt. And given that the threshold for the review that's triggered in this bill is only having either party having $10 million in assets, every transaction that a health system undertakes that's listed in this bill would be subject to this review, including, fairly low-risk transactions like leasing office space. And we think that creates a fairly significant burden without a lot of potential reward or something to be gained from it. Additionally, the bill's so broad, we are concerned that it may fail to actually get at the very transactions it is looking to target because it is casting such a wide net. That was a lot of the feedback that we got from our folks, was excitement on the concept and wanting to have this discussion, but feeling that this bill as drafted really may not actually lead to a way to meaningfully identify private equity transactions. As was stated, it's hard. It's very challenging. A lot of various kind of corporate machinations that go into that. And so we've heard some interesting ideas from our members about different approaches to this, including around prohibiting the corporate practice of medicine and other things that just haven't had time to kind of get into a more in-depth conversation. But we are committed to continuing to engage with, and I'm sorry I failed at the beginning of my remarks to acknowledge and thank Dr. Jacobs and the MHCC for reaching out to us. We've had several conversations about the bill and really want to continue those conversations in a very meaningful way.
Thank you for your testimony. Are there any questions from the members for this panel? Vice Chair Cullison.
I want to thank you all.
Absolutely. Yes. Always.
Yes.
All right, thank you very much. Seeing no further questions, this
you.
concludes the hearing on House Bill 944. We're going to jump to House Bill 772, which is Work Group on Behavioral Health Rate Methodology Modernization Establishment. Delegate Shetty, if you want to bring your panel, and you can begin your testimony when you're ready.
Hi, friends. So good to be back here. I'm like an honorary member of this committee. I love it. I love it. Ooh, we got a fun, spicy panel for you today. Spicy. All right. Okay, friends, I'm coming fresh off the Medicaid budget hearing, so I'm in a fun mood today. So anyway, thank you all for having us today. Chair Bagnall, Vice Chair Cullison, esteemed members of the absolutely wonderful House Health Committee. For the record, my name is Emily Shetty. Thank you for allowing me the opportunity to provide testimony in support of HB 772. This will establish a commission to develop a transparent, cost-based reimbursement methodology for certified community behavioral health clinics, CCBHCs, which I know the committee is super familiar with, and outpatient mental health centers, OMHCs. It will also require this work group to report out its findings on or before October 1st, 2027. Maryland continues to face a severe crisis in access to behavioral health. Demand for services increases while our providers struggle to remain financially afloat under outdated reimbursement structures which have not seen a meaningful rate increase in a decade. In fact, 10 years ago, this chamber passed a bill related to opioid overdoses that required the Department of Health to do an independent rate study on our behavioral health system. Some members who served on this committee, in fact, actually voted for that bill that became law. MDH notes in their opposition testimony that they're now doing this study 10 years later, after the bill went into law. I want to commend the department for beginning this process because our current rate methodologies are failing to reflect the full cost of delivering high-quality, comprehensive behavioral health care, especially for providers serving high-need and at-risk populations, like those who live in poverty and are underserved youth populations. I want to take a moment to actually focus my comments on Maryland Department of Health's opposition to HB 772 due to its belief that this new work group would be duplicative because of the HOPE Act of 2017 and other work that's being conducted by the agency. I also want to thank the department for sharing their testimony this morning after I requested it from them. While I am pleased to hear that the rate study is finally underway, I want to share the following. First, we don't believe that the bill is duplicative because it fills critical gaps in MDH's current process. The department is focused on developing cost report templates and single-phase rate studies limited to data capture and then review. What this bill does is go further. It requires actual development of transparent methodologies and long-term system alignment, none of which MDH's current contract requires. The HOPE Act, the law that passed 10 years ago that required this study that the department is doing now, the obligations under it do not include OMHC and CCBHC methodology modernization. What the HOPE Act did do is it required MDH to conduct a cost study, not evaluate and modernize. HB 772, the bill before you today, explicitly requires the development of cost-based methodologies across outpatient services, including comparing PPS, fee-for-service, hybrid, and acuity-based elements. MDH's testimony confirms that they are not doing this work. MDH's CCBHC work is narrow, and it's driven by federal grants, while this bill is system-wide. MDH cites that the planning grant tasks and the 2025 JCR requirement to complete a cost-saving study for CCBHC. That study does not cover OMHC rate methodology, workforce cost modeling, integration of OMHC and CCBHC financial structures, or system-wide rate coherence. HB 772 strengthens MDH's effort by consolidating and integrating data, not replacing the studies that they are doing. What the bill does is it explicitly calls for using the ongoing cost studies as baseline inputs, avoiding duplication. MDH's testimony confirms its contractor will not complete cost reports until March of 2027 and desk reviews until June of 2027. But this bill provides a structure to interpret the data collaboratively, which methodologies could then be transparent and implementable. The bill incorporates workforce and regulatory cost pressures, something that is not explicitly required by MDH's current process. MDH raises concerns about PPS restrictions, but the bill doesn't mandate PPS for OMHCs. Their interpretation is incorrect, as HB 772 requires developing methodologies, not adopting federally mandated PPS for OMHCs. Sixth, MDH's opposition does not address the workforce crisis, but we know that that is the primary rate driver. Maryland's system failures are due to outdated rates, not lack of data collection. The department focuses almost entirely on data capture, and the bill is the only mechanism that systemically addresses structural failures and seeks to do so in partnership with the department, not in conflict with it. Last, the bill provides the governance structure MDH currently lacks. MDH's testimony mentions stakeholder meetings, but it doesn't describe a formal, accountable, inclusive structure within MHCC that will ensure data is turned into policy, not shelved into technical reports. HB 772 is an accountability mechanism and one that is not duplicative, but instead complements the work that the department is already doing. It is an opportunity to meaningfully bring advocates back to the table at a time that it's critical for our providers to feel like they are being compensated for the work that they perform. The bill is receiving overwhelming buy-in from practitioners. As you can see, there are over 24 letters of strong support and several requests for amendments to specifically widen the categories of the commission members so that their organizations can provide input. This shows that there needs to be sustainable reform and that our mental and behavioral health practitioners want to be heard, and they are not being heard currently in the current study. We should not let another year go by without meaningful input into a process that our behavioral providers can place their trust in. This approach is both fiscally responsible and needed. I strongly urge the House Health Committee to issue a favorable report on HB 772, and I'm more than happy to work with stakeholders and the committee on any amendments that are required. Thank you, Madam Chair.
Good afternoon, Chair Bagnall, Vice Chair Cullison, and members of the committee. My name is Nicole Grainer. I'm the Policy Director with the Community Behavioral Health Association of Maryland. CBH represents 95 community-based behavioral health providers across the state, including OMHCs and CCBHCs serving individuals in Maryland's public behavioral health system. We are here today in strong support of House Bill 772. Through the HOPE Act, Maryland law has required an independent cost-driven rate study for community behavioral health services, as you heard, since 2017. And that work is now beginning to get underway, and we do appreciate the department moving that forward. House Bill 772 builds on this effort. The HOPE Act required a cost study. House Bill 772 strengthens the structure around how rates are set. It formalizes provider participation. Consultation is not participation. Providers need a seat at the table when methodology is shaped, cost drivers are identified, and implementation options are being evaluated. Policy ideas may look good on paper, but may unintentionally destabilize systems in practice. This bill ensures operational realities are part of the analysis from the beginning. It also ensures independent transparency. Rate setting affects whether providers can sustain services and whether Marylanders can access care. Housing this work within MHCC strengthens confidence in the final recommendations. The bill directs the work group to use cost data already being collected, including the CCBHC cost reporting data that is tied to the demonstration application to guide its work. So this is not a separate process and does not delay moving CCBHCs forward. Modernizing rate methodology is about aligning payment with the cost of delivering care and creating a process that all stakeholders can trust. CBH respectfully requests a favorable report on House Bill 772. Thank you.
Good afternoon, Chair Bagnall, Vice Chair Cullison. I am Carrie Guthrie, President and CEO of Cornerstone. We are one of the original CCBHCs in Maryland, supported currently with SAMHSA grant dollars. We provide services across the continuum of care, from residential to outpatient mental health clinics. Cornerstone's experience demonstrates the devastating impact of a lack of rate methodology. Since Cornerstone took over 3 of Montgomery County OMHCs in 1999, we have budgeted annual losses of up to $1 million for that program. One of the reasons that Montgomery County privatized their clinics was the Medicaid rates could not support the county's salaries, and they could no longer afford to do it. Cornerstone continues to have the same issue. OMHCs are our most costly service because of the cost of the licensed providers that are required. We have not been able to match salaries with many of our competitors, losing candidates and staff to government, schools, and hospitals. But we continue to provide these services. They are key to our mission, and we count on other service lines to make up the loss. The problem with that is over time, you impact the stability of the entire organization with ongoing deficits. What has that meant for Cornerstone? It means we have had turnover as high as 40% while coming out of COVID. It means that we closed intake of new clients even as need increased because we did not have the staff to serve them. While other positions are filled in less than 30 days, the clinic licensed positions take over 3 months to put in place. It means that we have had to purposefully shrink 3 programs' capacity: ACT by 100 clients, residential crisis by 8 beds, and behavioral health homes by 250 beds, because we did not have the staff to provide the services. That annual $1 million loss in the OMHC could have paid for a lot of salary increases over the years. Rate setting for CCBHCs and OMHCs can stabilize workforce, access to care, quality of care, and sustainability of care. We respectfully request a favorable report on House Bill 772. Thank you.
Good afternoon, Chair Bagnell, Vice Chair Cullison, and members of the Health Committee. My name is Marshall Henson. I'm the Chief Operating Officer of Community Services at Sheppard Pratt, the nation's largest private nonprofit behavioral health system and Maryland's statewide safety net provider. We serve more than 80,000 patients a year. We strongly support House Bill 772. Across our 380 sites of care, from OMHCs to CCBHCs to crisis services, inpatient hospitals, residential programs, and school-based mental health, we see the same challenge every day. Maryland's outdated and non-transparent rate methodologies make it increasingly difficult to deliver timely, high-quality outpatient behavioral health care. HB 772 provides a practical, data-driven solution. The bill establishes a structured work group within the MHCC that finally brings together providers, state partners, and system experts to modernize the rate-setting methodologies. Importantly, it builds on the cost studies already underway, examines the real cost drivers like staffing, supervision, regulatory requirements, and geographic variation, and it aligns those new methodologies with federal Medicaid financing rules. This matters because outpatient care is the backbone of Maryland's behavioral health system. OMHCs and CCBHCs particularly need attention regarding the rate setting, as both models currently operate under fundamentally different reimbursement approaches. Even though they share the same workforce, regulatory obligations, and clinical needs, this fragmentation has led to misaligned incentives, operational inefficiencies, and barriers to same-day access, as well as integrated care, crisis diversion, and long-term stabilization. And most urgently, we cannot stabilize Maryland's behavioral health workforce without reimbursement rates that reflect the true cost of care. Vacancy rates of 20 to 30%, wage competition, and reliance on contractors directly reduces access in the system. For these reasons, Sheppard Pratt respectfully urges a favorable report on HB 772. Thank you all for your time and your leadership.
Good afternoon, Chair Bagnell, Vice Chair Cullison, and esteemed members of the Health Committee. My name is Stephanie Slowly-Little, and I have the pleasure to represent 10 local affiliates and serve as the Executive Director for the National Alliance on Mental Illness in the Maryland chapter, which is representative of 60,000 advocates, members, persons living with, and families that support those who are suffering with mental illness. And we come today with our panel to ask for a favorable report on 772. The work group would ensure that the rates reflect the true cost of employing a team of capable team that's delivering high-quality, evidence-based care. This work group would seek to understand how to attract and retain licensed clinicians within a highly competitive market and are leaving the community-based care at a vast rate. Modernizing these rates ensures providers remain viable, that when reimbursement fails, we know that the actual cost of care and the quality of care fails. We are asking that that we know this directly correlates to wait times in the ED. We already see that happening in Maryland. This bill explicitly includes OMHCs and community-based, certified-based behavioral health clinics and the need to really address these rate-setting methodologies to ensure that Maryland builds upon the success that's been demonstrated and that we ensure that clinical services are met. Personally, for the people that we work with and serve every single day, it matters where they go, who sees them, and how the services are rendered. And when they are not adequately compensated, they're not bringing their best to the table, and the people that they serve suffer. So we ask you to consider that and provide a favorable report for 772. Thank you for your time and your consideration.
Thank you for your testimony. Are there questions from the members for this panel? Seeing Delegate Kaufman.
Yes, my question is for the woman from Cornerstone, Rate Montgomery County Organization. You said that you typically, one of your programs has $1 million loss, correct?
Yes.
And so do you know of other organizations like yours, or has Cornerstone even contemplated it, where eventually organizations cry uncle and close because they can't keep up with the losses and going into reserves?
Thank you very much for the question. And the answer is yes. I could list a few agencies similar to ours who have closed their clinics across the state, some several years ago and some more recently. I think that is a challenge. We have often looked at it. I've had a board who's sometimes looked at me and said, seriously, are we going to keep supporting this program that loses so much money? We have been able to make improvements. Some things have gotten better, but we are still, this year alone, we still budgeted over a $500,000 loss in the clinic, close to $750,000. So it is still a huge challenge because the rates just do not cover the salaries of all those licensed people, the psychiatrists, the nurse practitioners, the therapists. So it absolutely is something that people consider and have closed down the clinics.
Thank you, Madam Chair.
Delegate Johnson, followed by Delegate Hill.
Thank you, Madam Chair. This question is for Ms. Grainer. Why do you think it's important for stakeholders like Community Behavioral Health Association of Maryland to have input into the methodology of the state's cost study?
Sure. Excuse me. That's a great question, Delegate Johnson, and thank you for it. We think early involvement of stakeholders ensures that the cost study can be pinpointed and detailed enough to effectively achieve the state's goals. In the department's past efforts, CBH has noted and actually shared concerns that the sampling methodology and cost study template weren't adequate to accurately reflect provider costs. When we're looking at methodology, we specifically think it's important to look at excluding organizations that have a history of poor performance concerns, that we want to make sure that it differentiates providers between for-profit and nonprofit, as they have very different staffing models, and the cost of those are very different. And also making sure that it addresses the provider's both service array and individual services. And so when we're not brought into the table at the beginning of that, often the things that are put forward aren't going to work in practice. And when we've shared those concerns, they've actually pulled those cost studies, and that's part of why we're in the position that we're in now 10 years later.
Thank you. Thank you, Madam Chair.
Thank you.
Delegate Hill.
Thank you, Madam Chair. I'd like to address this to the woman from Cornerstone, just following up on Delegate Kaufman's question. So from a business standpoint, I mean, those of us who've had businesses, we understand that sometimes when you lose money, it means that you're not taking home much, or you're eating, or you're living off some other source of income. How do these businesses, if they're seeing this amount of loss on a regular basis, reverse question, how do you keep your doors open? If you're not covering costs, how are you keeping your doors open?
Thank you for the question. It is a good one. As I said in my testimony, we made the choice to continue to provide those services even though they were at a loss, because we knew that we had other services that could make up the difference, that could cover that loss. What that means is, as a nonprofit, when we do our budget for the year, our goal is to break even. Honestly, 15 years ago, or more than that, I guess now, 20 years ago, when we didn't have clinics, we tried to have a little buffer, a little cushion, so that we could plan for, salary increases and things of that nature. Now, in the last 10 years, our goal is to break even, and that is just the challenge that we're in. That's the world that we're living in, and that's what the current situation of rates allows us to do. It's not where we want to be. I'm the first person to say a nonprofit is a business like any other for-profit. And we have to run things the same way as everybody else. And if we show a positive bottom line, that's wonderful, because we're going to reinvest that right back into the organization, most often in salary, because that's been one of our challenges since we opened 50 years ago. So it is a challenge. We are lucky that we do have other services that do bring in more revenue, that the staff are easier to hire, and we bring those folks in and we're able to maintain those services. COVID was a hit, but we've been able to stay on top of most of those services. But that's how we're doing it.
May I follow up? Okay. So these other lines of services, are they also medicine providing services that have restrained reimbursements, or they are services you provide that are completely outside of any kind of reimbursement?
They are all Medicaid services. That's who we provide services to. But some of the other ones, the way they are reimbursed and the staffing that we use, it allows for there to be some cushion. So for example, residential rehabilitation, our supported employment program, both of those are programs that can show a profit. Targeted case management has been another program in Southern Maryland that we have that has shown a profit. Not a huge profit, but enough that we can offset the expenses of the clinic. I'll be honest, if you look at our 990 or at our financials for FY25, we lost $2 million that year. So we've been able to absorb it, we've been able to keep going. So even when we show a loss, we are still being able to move things around and make it happen. But I don't know how much longer we'll be able to do that.
All right,
But yes.
Thank you very much. Thank you, Madam Chair.
Thank you. Seeing no further questions, I'm just trying to understand the opposition and the bills in parallel. And as I understand the letter of information and the opposition, it seems like we're engaged in essentially a cost-benefit analysis, a two-pronged cost-benefit analysis. But it seems your bill would work in tandem with that. Is that correct? That because it would help us avoid rate setting based on flawed data.
Correct.
And would that allow us to get more upstream from where we are now?
That's the hope. So thank you, Madam Chair, for the question. That is the hope. Because we received the feedback from the department this morning after request, the detailed response that I provided could not be incorporated into my written testimony, but I'm more than happy to share that with you so that you have like all of the information before you, and the committee has that as well. Yes, that is the goal. There are, the key distinctions are, one, that under our bill, the MHCC is doing the study, which makes it truly more independent than the current study that is being done. And two, that it really does incorporate more and centers stakeholder engagement to create the methodologies that are needed.
So in theory, we would get more accurate data as to what we're actually seeing in our systems.
Yes, thank you.
Thank you very much. Seeing no further questions, this concludes the testimony of this panel. Thank you very much. We do have one favorable with amendments, and that's Andrea Mansfield. You want to come to the table and go ahead and give your testimony.
Great. Thank you, Madam Chair, Madam Vice Chair, members of the committee. Andrea Mansfield, representing the licensed clinical professional counselors of Maryland. And as I'm here today, supporting this piece of legislation with amendments. And actually, our amendments would do two things. One, provide a representative on this work group for the licensed professional counselors, as well as kind of broaden the scope slightly to also include independent outpatient settings. The clinical counselors, they do work with the same population. Some of the clinical counselors actually work within the settings that the previous panel are within and work within. And some of these are also small single practitioners. So they're really, they're also, their operations and business, they're really, managed by the rates, and we want to ensure they can cover their costs as well. So really, they are providing the same type of comprehensive healthcare and services, and they really believe that by examining the rate setting reimbursement methodology across the full spectrum of providers would really serve to expand the number of providers out there to serve people in need, as well as improve access overall. So with that, we support the piece of legislation with amendments. Thank you very much.
Thank you for your testimony. Are there any questions for this witness from our members? Seeing none, thank you very much for your testimony. We don't have any in-person unfavorable, unfortunately, so we'll have to regroup and get our questions answered at another time. Thank you very much. This does conclude the bill hearing on House Bill 772, and we're going to move to House Bill 965, which is the Office of Healthcare Quality Stakeholder Advisory Council Establishment. Delegate Warman, if you want to come to the table and go ahead and bring your sponsor panel, and you can get started with your testimony when you're ready.
All right. Thanks for hanging in there.
Just before you get started, let the record reflect that our members have just been presented with the addressing the opposition for the previous bill. So we have, you should all now have that in your, sorry, no, for this bill. All right, so, and Delegate Warman, if you want to go ahead and get started.
Thank you, Madam Chair. Thank you, fellow committee members, Vice Chair Collison, and for the record, I'm Delegate Teresa Warman, representing District 16. Thank you for the opportunity to present House Bill 965. As you all know, the Office of Healthcare Quality is charged with ensuring minimum standards of care across Maryland's hospitals, nursing homes, assisted living facilities, and other regulated settings. This is an enormous responsibility. OHCQ oversees tens of thousands of providers across dozens of industries. The health and safety and dignity of Marylanders depend on that work being strong, transparent, and trusted. In recent years, we have seen extended emergency room wait times, inspection backlogs, and troubling findings highlighted in national reporting regarding oversight failures. These realities underscore the need for stronger communication, transparency, and structured stakeholder engagement. HB 965 is a modest, structured response. It would establish a 22-member stakeholder advisory council within OHCQ. It is non-regulatory. It is an advisory only. It would meet virtually twice a year, and it provides a formal forum for reviewing aggregate oversight data and compiling stakeholder recommendations in a publicly posted summary. After each meeting, it would be reported out number of hospitals that are actively monitored, nursing homes inspected, complaints received, violations identified, average response times, and complaints resolved. The council then compiles all of this feedback into a public summary with recommendations. It does not change regulatory authority, does not conduct inspections, does not conduct confidential patient records, does not override the department. It just creates structured transparency and a feedback loop. It's not a novel experiment. More than federal agencies operate under advisory councils under the Federal Advisory Committee Act. They're proven governance tools that strengthen accountability and responsiveness. And I will add, since some news coverage reported that I was introducing this bill, individuals within OHCQ have reached out to me raising concerns about internal communication gaps, operational challenges. I'm not here to litigate those conversations publicly, but they reinforced for me that this is an office with an enormous mandate and extraordinary pressure, and that structured transparency strengthens systems rather than undermines them. Now, this is typically where my testimony would end, but I know this committee, and I want to briefly address the opposition arguments. We passed out something on my letterhead that I'll submit for the record as late testimony if need be, that addresses the majority of the concerns that are being raised. We have been working on this bill with advocates and stakeholders since this last summer. Throughout that process, we invited feedback early and often. Those who requested changes during drafting saw those changes, saw those concerns incorporated either directly into the bill language or through amendments. What is notable is that majority of the entities now in opposition did not propose substantive changes to improve the bill structure. However, many of the conversations centered not on narrowing or clarifying the proposal, but on expanding representation of membership. The AG's office asked us to remove them from the bill, so we did. We worked collaboratively with across the street to do that, because we do have a Senate sponsor. This has been an open and good faith process, and the bill before you reflects months of engagement and thoughtful revisions. Like I said, I placed a handout, and if you guys want to refer to it real quick, it kind of just organizes the concerns raised by the Department of Health, the Department of Aging, the Maryland Hospital Association, Lifespan, and a local commission on aging into 6 different categories that just outlines what each claim is and what the reality is, and I wanted to just make it easy for you to look at. It kind of falls into 6 different buckets: duplication, lack of expertise, confidentiality concerns, regulatory overload, claims that backlog is improving, and staff capacity, and I'll just briefly address them. On the duplication of oversight, if you look in your documents there's also a Venn diagram that shows you exactly what this program that we're trying to establish is not a duplication of program oversight. The Department of Aging Committee that is referenced in the testimony focuses specifically on long-term care programs, nursing homes, assisted living, and our bill would evaluate OHCQ's regulatory performance across all regulated facilities, including hospitals. One reviews care programs, while the other is regulatory performance, and that is just layered accountability, not duplication. Second, expertise. It says that the council does not make clinical decisions. It does not it does not override OHCQ. It reviews the public metrics, response times, complaint resolution data, and inspection frequency. Public accountability does not require hospital CEO credentials. It requires transparency and engagement. Confidentiality. There's nothing in this bill that requires disclosure of protected health information. OHCQ already handles protected data and routinely reports aggregate findings. The council would review de-identified aggregate metrics. The fourth one is that there are too many regulators and bureaucracy. This bill does not regulate the providers. It evaluates OHCQ's performance. There's a difference between enforcement and oversight between regulatory enforcement and oversight of a regulator. Fifth is that the backlog is improving. I'm pleased to hear that improvements are being made, but oversight is not punishment. This council ensures that progress is sustained, measured, and publicly reported. And finally, staff capacity. The suggestion that 2 virtual meetings per year reviewing existing aggregate data would require an equivalent full-time position is difficult to reconcile with the bill scope. Even under generous assumptions, we are discussing roughly 8 to 10 hours annually, less than 0.5% of the full-time position. And I'll say this gently, even in the testimony, you'll see something within my own county. The county's Intergovernmental Affairs Office submitted testimony supporting this with some amendments, while our local Commission of Aging submitted testimony on opposition. That contrast illustrates exactly the kind of why structured engagement matters, and that sometimes stakeholders operate in silos, and this bill creates a shared table. This bill is modest and should be cost-effective. It is collaborative, as you'll hear from the witnesses here today, and it strengthens public trust in a regulatory system that really carries immense responsibility. We deserve high-quality care and confidence that oversight is transparent and responsive. Thank you for your time, and I request a favorable report.
Madam Chair, Vice Chair, and committee members. I'm Dr. Anna Palmisano. I'm the Director of Marylanders for Patient Rights with the largest patient advocacy coalition in the state, with a collective membership of over 1 million Marylanders. The Stakeholder Advisory Committee or Council for OHCQ will help to improve their vital oversight function and the quality of care in Maryland. By now, I know all of you are aware that Maryland has ranked among the worst ER wait times for a decade, worst in hospital patient satisfaction, and timely nursing home inspections. Moreover, the Washington Post reported numerous violations in Maryland adult daycare and an alarming increase in preventable medical errors, some fatal, in Maryland hospitals. So the Stakeholder Advisory Council is modeled on the highly successful federal advisory committees, which have been established across the federal agency for 5 decades. As a senior executive at the U.S. Department of Energy, I found standing advisory councils were very helpful in providing leaders with thoughtful advice and guidance. These advisory groups serve a non-regulatory function, but instead they promote engagement, accountability, transparency. The model has proven to work across federal agencies and also has a precedent at the state level in Massachusetts. Council membership will be diverse with patient advocates, healthcare workers, industry representatives, and government officials that bring knowledge, insight, and lived experience. Council members will meet virtually twice a year to minimize costs and workload for OHCQ. Meetings will be live streamed and time allowed for public comment, and the minutes will be posted. The Stakeholder Advisory Council will help OHCQ by providing constructive feedback, improving effectiveness, and restoring public trust. I respectfully ask for a favorable report on HB 965. Thank you.
Good afternoon, Chair Bagnall. My name is Tamlyn Kelly, and I'm here today on behalf of Disability Rights Maryland to express our strong support for House Bill 965. OHCQ has an essential function in ensuring that all of us are safe when we receive healthcare services. While the responsibility entrusted to OHCQ is great, there is too little public oversight of their work. We support this bill because it will increase transparency, it will improve the timeliness of investigations, and it will ensure the effectiveness of the process to correct problems that have been found in facilities. I'd like to share a few examples from our experience. First, Disability Rights Maryland is still waiting for OHCQ to investigate 4 complaints that we sent in 2021, including complaints about the improper use of chemical restraints and a complaint about alleged abuse of a patient by a staff person. Secondly, in 2022, Disability Rights Maryland sent a complaint about illegal prolonged seclusion of people with disabilities occurring in a Maryland hospital. OHCQ did not investigate this complaint for several years until we resubmitted an updated complaint for the same issue last year. We later learned that in 2023, while we were waiting for them to investigate our complaint, 12 people in that hospital spent more than 700 days in prolonged seclusion. This included one man who spent 322 days, or most of that year, in prolonged seclusion. As you may be aware, when OHCQ investigates, when they find a violation, they develop a plan to address the concerns. However, too often, investigations cite the same repeated concerns. Repeated findings have even been cited in patient deaths. Examples of repeat findings include that a hospital's medical staff lack current CPR certification and that a hospital doesn't have hot water. An advisory council will help to ensure that when OHCQ finds dangerous conditions, we can be sure that the facilities are closely followed until the conditions have been resolved. For these reasons, Disability Rights Maryland urges a favorable report.
Good afternoon, Chair Bagnall and members of the committee. Thank you for the opportunity to testify in support of House Bill 965, which seeks to establish a stakeholder advisory council to support the work of the Office of Healthcare Quality. My name is Sarah Westrick, Advocacy Director for AARP Maryland, here representing our 850,000 members in the state. Thank you to Delegate Worman and all the sponsors of this bill. OHCQ plays a vital role in overseeing the quality of care provided in our state's healthcare facilities. This bill takes a crucial step towards enhancing OHCQ's effectiveness by creating a stakeholder advisory council that will provide valuable feedback and recommendations to the office. The council, comprising diverse stakeholders such as frontline hospital workers, industry representatives, and advocacy groups, including AARP Maryland, will bring a wealth of knowledge and expertise to the table. By periodically engaging with these stakeholders, OHCQ will gain a deeper understanding of the challenges and concerns faced by healthcare providers, patients, and families, and ultimately this will help lead to more informed decision-making and better outcomes. In addition, holding virtual public meetings every 6 months will provide opportunities for public comment, helping build transparency and accountability. This will not only foster trust among stakeholders, but also provide a platform for the public to share their concerns and experiences, which is essential for driving meaningful change. We believe HB 965 has the potential to significantly improve the effectiveness of OHCQ and ultimately the quality of care provided in our state's healthcare facilities. AARP respectfully urges a favorable report. Thank you.
Good afternoon, Chair Bagnall and members of the committee. My name is Lorraine Arikat. I'm the Senior Policy Analyst with 1199 SCIU. We're the largest healthcare workers union in the nation, representing over 10,000 here in Maryland across the care continuum in hospitals, nursing homes, and federally qualified health centers. We support HB 965 because in a time where we are experiencing devastating healthcare cuts, we as a state must work to uphold quality of care and hold healthcare facilities accountable. It has always been and always will be patients and healthcare workers sounding the alarm when facilities make fiscal decisions that diminish quality of care. Our nursing home members know that in Maryland, our nursing homes experience a churn of new owners, and with each change, the decision owners make is to cut staff, leaving facilities understaffed to care for vulnerable seniors needing more care. We have over 70 facilities in Maryland identified as having serious problems, and for all the residents who live in those facilities, it is both shocking and unacceptable. It reflects systemic failures within parts of the nursing home industry and a breakdown in government oversight and enforcement of the minimum standards designed to safeguard residents and ensure the appropriate use of taxpayer funds. We applaud OHCQ for diminishing their overdue inspections of nursing homes from 173 in 2023 to 12 in 2026. But there's still remaining questions on the information from those inspections and the quality of nursing homes. As a Baltimore constituent, it's alarming to see the number of known unlicensed assisted living facilities operating and the hundreds of calls coming from patients, families, and caregivers that reveal one thing, that as people need support, government agencies keep looking away. The Office of Healthcare Quality needs the voices of patients, advocates, and healthcare workers at the table to fix negligent care and hold facility owners and management accountable. This bill would restore public trust and transparency, include all relevant stakeholders, and lay the foundation for open dialogue and problem solving within the Office of Healthcare Quality. For those reasons, we urge a favorable report. Thank you.
Thank you very much for your testimony. Are there questions for this panel from, or the sponsor from our members? Seeing none, thank you for your testimony. Delegate Riley.
Sorry, a little late. We got a lot going on over here. Thank you, Madam Chair. So I guess this is for Ms. Palmello, or how do you say her name? Or
Palmisano.
Anna Palmisano. So anyway, so I believe when we met, you said that there were other states that have incorporated something like a stakeholder advisory group, and if so, could you explain if that has been helpful or not helpful, and how do they collaborate with the agency?
The state of Massachusetts formed a stakeholders group in 2023. And so far, though it's still pretty young, it seems to be having a good effect on Massachusetts, you know, in their metrics of healthcare, which have always been much better than those of Maryland.
Okay, and is this particular bill, I'm sorry, follow up? Is this particular bill aligned with the same language as the one?
It's very similar. Their stakeholder groups may vary a bit, but it's a similar concept of getting a variety of stakeholders together to help to improve the oversight of healthcare.
Okay, thank you very much, and
Thank
thank
you.
you, Delegate, for the bill.
Delegate Hutchinson.
Thank you, Madam Chair. My apologies for coming in late, so I'm trying to come up to speed quickly. And gosh, I keep seeing lots of commissions being formed here in Maryland. Rather than creating a new commission, why aren't we just going back to the existing commission and expanding the scope of what they do? Or is it apples and oranges that I'm talking about?
I'm not aware of an existing council, and we're talking a council, which would be a standing committee that covers the breadth of OHCQ's mission. So this would be novel.
Okay. So I'm looking at sorry, Madam Chair. I'm looking at the sheet that I have in front of me that you said about the opposition, and it says it duplicates, there's a claim that it duplicates the Department of Aging Oversight Committee. So I guess I was thinking of that committee and saying, are you looking over that committee? Is that what this committee is overlooking, that committee? Or why aren't we just expanding the duties of that committee to do the things you want to have done?
That committee is just limited to that facility, that type of facility. What this is trying to do is oversee what OHCQ oversees, not a specific program.
I understand. Thank you so much.
Thank
Oh,
you.
and there is a Venn diagram in your documents. Yeah. Could I add one more thing?
Yes.
And the other thing about that commission is that it's overseen by the Department of Aging.
Seeing no other questions, I kind of had a follow-on with Delegate Hutchinson, Delegate Riley, because I do see that they are unique. And in fact, the Oversight Committee on Quality of Care in Nursing Homes and Assisted Living Facilities was created in 2000. It was renamed in 2005. It was modernized in 2018, and we expanded the scope. And yet, we seem to still have concerns. And we know that the Department of Aging has talked to us, in the Office of Healthcare Quality has done reporting that they're catching up on the backlog. And I think there is, up to Delegate Hutchinson's point, how do we make sure that we're not creating commissions to oversee commissions to oversee commissions? But I also recognize that we have heard multiple reports of concern, and that we have had legislative audits of concern. And so I have several letters of opposition, and so I'm going to just encourage the good delegate to do the work that I know that she's going to do in working with them, and perhaps identifying, to Delegate Hutchinson's point, existing resources that maybe we reconsider and alter their charge, and perhaps expand their membership to be representative of the work that you are looking to do in this bill.
The Department of Aging isn't going to do families and children.
Well, yes, I agree. We'll reach consensus on this one, but I do want to point out, this is Department of Health versus Department of Aging. It's kind of what.
And agreed. And the scope of this is much broader than the Department of Aging, because I see that it represents our hospitals, our health facilities, our long-term care facilities, as well as assisted living. And we've been sort of like, chipping away in that one area, but we really need to, I think you're looking to take a broader brush is what I'm seeing. So thank you very much. This concludes the testimony of this panel. We do have one panel of, sorry, my things are out of order. Okay, we have a favorable panel in person and a favorable panel virtual. So let me start with Ann Geddes and Megan Peters.
quick. Hi. Thank you, Madam Chair and committee members. I'm Ann Geddes. I'm the Director of Child and Older Adult Policy at Mental Health Association of Maryland, here in support of House Bill 965. And I want to talk about nursing homes because people with serious mental illness can be especially negatively impacted by poor quality nursing homes. About 25% of people residing in nursing facilities have been diagnosed with a serious mental illness. And many studies have shown that people with serious mental illness who are in nursing facilities are in nursing facilities that provide much worse than average care. The failures of the Office of Healthcare Quality over the last decade to adequately inspect nursing homes and investigate complaints are well documented. Fortunately, new leadership at MDH and OHCQ has brought about some improvements, and the legislature took significant action last year to ensure better oversight of OHCQ. HB 96 would just further enhance protections for people in nursing facilities by establishing the advisory council that could evaluate the agency's work, provide constructive feedback, and report to the Secretary of Health if needed. Therefore, we ask for a favorable report. Thank you.
Good afternoon, Madam Chair, members of the committee. For the record, Megan Peters here on behalf of the Alzheimer's Association in support of House Bill 965. We support this bill because Maryland needs regular, transparent way for stakeholders to engage with OHCQ and how our facilities are being overseen. People living with dementia are among our most vulnerable residents in our care settings, and many can't report concerns themselves, which makes strong state oversight essential. Unfortunately, we've seen what happens when oversight breaks down. The consequences for people with dementia are very real: preventable injuries, untreated medical conditions, or unsafe wandering. The state has been working to address its lapses in oversight, and we appreciate that progress. But after years of issues, we need a regular way for stakeholders to stay engaged and help prevent these failures. House Bill 965 provides that ongoing engagement, bringing transparency, accountability, and collaboration to the forefront and improving safety. And for these reasons, we urge a favorable report. Thank you.
Thank you for your testimony. Are there any questions? Delegate Hill.
Thank you, Madam Chair. Ms. Geddes, thank you. You mentioned the legislation that we passed last year. So should we give it a little bit more time to play out? Or would you have wanted this last year too? Was it not enough? I mean, again, this oversight board has no real authority. It's just sort of a finger pointing, light holding thing. So why?
Yeah, I mean, certainly the legislation passed last year is already making things better than they were. And like I said, new leadership, things are better than they were. But we believe that a transparent process with stakeholder feedback, people who are really on the ground, working with consumers who are experiencing various difficulties, would be really beneficial. And we could provide constructive feedback.
Okay, thank you.
Seeing no further questions, we do have, I'm going to try and be balanced because we have a favorable with amendments, and then we've got an unfavorable, and we've got one favorable of virtual. So let me go to favorable with amendments, which is Peggy Shimoda.
Thank you, and good afternoon, Chair Bagnall, members of the committee. For the record, my name is Peggy Shimoda, and I'm the Executive Director for the Hospice and Palliative Care Network of Maryland. So I have also submitted written testimony for this bill, but I just want to briefly highlight our support for HB 965 and our requested amendment. The network represents hospice and palliative care providers across Maryland who collectively serve more than 25,000 Marylanders each year, and they are served in homes, nursing facilities, hospitals, and hospice houses. We support the intent of this legislation to strengthen oversight, accountability, and collaboration through the Office of Healthcare Quality Stakeholder Advisory Council. These goals really do closely align with our mission, which is to advance quality, access, and patient-centered care. However, we respectfully request an amendment to include a designated seat for the Hospice and Palliative Care Network of Maryland, or language that allows us to appoint a representative of the network. Hospice and palliative care providers bring specialized expertise in caring for individuals with advanced and life-limiting illness. Our members operate across care settings, giving us a true cross-continuum perspective. So we feel we could be very helpful in that area. Decisions related to quality oversight, care coordination, and system performance directly impact seriously ill Marylanders, including Medicaid beneficiaries, rural communities, and pediatric patients. Including hospice and palliative care ensures that equity, cost-effectiveness, and patient-centered goals are fully considered. As Maryland's recognized statewide association, we provide a coordinated voice representing the full continuum of serious illness and end-of-life care. For these reasons, we respectfully request a favorable report with the amendment outlined. Thank you so much.
Thank you for your testimony. Are there any questions for this witness from our members? Seeing none, thank you very much for your testimony.
Thanks so much.
We are going to go to an unfavorable. We have one unfavorable virtual. Do we have Seth Miller? Okay. Mr. Miller, you can begin your testimony.
Madam Chair and Committee, first, thank you for your service. Seth Miller, unfavorable. First Amendment, public men, brackets, and women are public property. New York Times v. Sullivan. If I'm to be arrested, please bring a wheelchair and accompany me from the front. I'm disabled. In the United States, dignity and decorum of government exists not to elevate governing over governed, but to remind office holders of an oath of office. James Madison famously said, "Good men, brackets, and women will make bad laws workable. Bad men, brackets, and women will make havoc with the best laws." This bill is not nearly aggressive enough. As a short-term recovery patient at Potomac Valley Nursing and Rehab, I saw my friend and former roommate attacked twice. First by a third roommate, next by staff. It could have been me. I don't remember anything from the night of the accident, whereby I went from my life as a paralegal to my life as a patient. I remember vividly John beating Brian and laughing. I made a nurse call the police under threat of reporting her to the state if she did not call the police. Police report attached. No police report for second attack. OHCQ did nothing. COVID came. The Washington Post reports Potomac Valley had known COVID positives. They chose not to isolate known COVID positives. They chose to accept known COVID negatives. Of those accepted negative, 10 contracted COVID, 5 died. Had OHCQ listened when I complained about the attacks on Brian, staff would have gotten it together and those 5 would be alive. I asked for and received legislation on increased inpatient phone access. Thank you, Senator Stelling and Delegate Warman. I know neither of you supports my tough testimony. MDH came out against phones and cameras. MDH came up with a fairy tale that increased patient phone access would jeopardize CMS accreditation. The architect of that theory is no longer with MDH. OHCQ faced a class action for failure to conduct site surveys. Correspondence from OHCQ included shows that they just don't care. How many MDH officials left due to a failed record? James Madison famously said, "Good men, brackets, and women will make bad laws workable. Bad men, brackets, and women will make havoc with the best laws." The General Assembly telling OHCQ to shape up reminds me of my mother telling me not to pick on my brother. I call on CMS to take oversight survey function from OHCQ. I call on Governor Moore to support phones and cameras. I call on officials to return long-term care lobbying campaign money. How would Governor Moore feel if his mother was at his inauguration or at Potomac Valley? Leave no one behind, Captain.
Thank you very much for your testimony.
Thank you.
Are there any questions for this witness from our members? Seeing none, thank you very much for your testimony. We have one more virtual panel. Favorable, we have Brooke Rossheim and Ruth Carlock. Mr. Rossheim, you can go ahead and start your testimony.
Okay, well, first, can you all hear me okay?
Yes, we can.
Okay. Chair Bagnall, Vice Chair Cullison, and members of the House Health Committee. My name is Dr. Brooke Rossheim. I'm a Maryland licensed physician and specialize in public health, and preventive medicine, internal medicine, and geriatric medicine. My testimony is in strong support of HB 965. I'd like to focus on issues that may be raised against this bill. You may hear that HB 965 creates a council whose work is already done by the Maryland Department of Aging Oversight Committee on Quality of Care in Nursing Homes and Assisted Living Facilities. The MDOA committee only focuses on people who live in those facilities. The council's purview is far larger and addresses children, adults of all ages, and families. You may hear that HB 965 creates a council without subject matter experts. The council's membership is broad, including representatives from the Maryland Hospital Association, MedChi, the long-term care industry, healthcare workers, and many stakeholder groups. Whether professionally or personally, this group has knowledge and experience about facilities regulated by OHCQ. Regarding the finances of HB 965, the use of virtual meetings and AI technology will translate into an estimated cost of only about 1/3 of an FTE. Concern about data privacy may be raised. Only de-identified aggregate data will be shared with the council. This is a standard practice to protect privacy. Thank you for your consideration of HB 965, and we request a favorable vote from this committee.
Thank you for your testimony. If you can just stay on, we have one more virtual panelist, and then we'll open it up for questions. Ruth Carlock, if you want to go ahead and unmute and begin your testimony.
Good afternoon, everyone. Sorry, my voice is a little groggy today, just still getting over a cold. But my name is Ruth Carlock, and I'm the legislative liaison of the Brain Injury Association of Maryland, and I'm in support of HB 965. This bill would collect a diverse team of Maryland healthcare leaders and designated politicians with frontline hospital workers, nursing home workers, healthcare advocates, and those in care organizations several times a year to complete a public meeting to develop recommendations to improve the quality of nursing homes and hospital cares in Maryland. This change would add greater public feedback and accountability to the process, with public meetings focused on reporting the numbers of hospital monitoring, nurse home inspections, hospital patient complaints, and code violations. These biannual meetings would help build trust that has been lost by the ongoing issues of these healthcare industries. And according to data from 2024, Maryland currently has some of the longest wait times in the country when it comes to hospital wait times, with some Marylanders driving out of the state or to DC for emergency hospital care. Nursing homes have seen a consistent decline in quality among those living in a nursing facility as more people are needing care, with the need for services only increasing over the coming years with a rapidly aging retirement population. Currently, the Office of Healthcare Quality has seen issues keeping up with the demand for improving healthcare quality, and this bill will help return the vital oversight function to improve the declining quality of care in Maryland. As a case manager at the Brain Injury Association of Maryland, my clients come directly from nursing homes and hospitalizations. A client I've been working with for years, recently placed in a nursing home, has experienced neglect, minimal oversight, and a lack of transparency in getting information to his healthcare teams and family. These are issues that we see frequently among TBI survivors and their advocates, many desperate to get them out of these nursing homes and unable to meet their complex demands. Given the ongoing healthcare quality challenges in Maryland, the establishment of the Stakeholder Advisory Council is a necessary step in providing constructive feedback and advise to push healthcare in the right direction. We ask that you render a favorable report for House Bill 965. Thank you.
Thank you very much for your testimony. Are there any questions from the members for this panel? Seeing none, thank you very much for your testimony today. This does conclude the bill hearing on House Bill 965 and our bill hearings for today.